Good evening, everybody. On behalf of Department of Pulmonology, Yashoda Hospital, High Tech City, I would like to extend a very warm welcome to all of you for Precision Therapy in Pulmonary Medicine, which is a very focused program on specific diseases considering the recent advances in pulmonary medicine. To begin the session, I would like to call upon the stage Dr. Nagarjuna sir to say a few words, and then we can begin the academic session.
Thank you so much, dear Pratib. A warm welcome to everyone to the Department of Pulmonary Medicine, High Tech City. And this also happens to be the first event which we are organizing from this branch. And this is a concept which we have never focused on. So that is phenotyping and precision therapy in pulmonary medicine. So this we have chosen because we feel that this is going to be the future, and personalized therapy is going to replace common therapies which we are following now. So it's a very focused program of around 3 hours. We have 5 talks wherein 5 speakers will share their experiences on the precision medicine and phenotyping and its role in pulmonary medicine. So with this, I won't take much time, and we will start the academic sessions. We want to go on time. So I will now ask again Pratip to come and start the scientific sessions. Thank you.
Thank you, sir. To begin the session, I would like to call the chairpersons for the first session. I would like to call upon the dais Dr. Professor V. Pravakar Rao Garu. Sir, kindly join us on the stage. There. Sir is Professor Emeritus, Department of Pulmonology, MNR Medical College. I would like to call Dr. Narendra Kumar Narahari, sir, Additional Professor, Department of Pulmonary Medicine, Nizam Institute of Medical Sciences. He has more than 35 original publications in index journals. His special interests include interventional pulmonology and sleep medicine. Dr. Tapasvi Krishna ma'am, consultant pulmonologist, Gleneagles Global Hospitals, Hyderabad. She has vast experience in ILD, lung transplant, and stem cell therapy. And Dr. Mahender Biradar, consultant intervention pulmonologist, allergy and immunotherapy specialist at Maxted Hospital, Hyderabad. His special interests are in severe asthma and intervention pulmonology. Sir, may I request you to call upon the first speaker on the dais.
Hello, good evening to all of you. I invite Dr. Nalini to deliver her first talk on sleep medicine. In fact, it gives me a lot of pleasure to share with you all that the sleep medicine has become a part and parcel of our pulmonology. And I share my happiness that I was the earliest physician who had training in the sleep medicine at University of Calgary. And recently I addressed one international conference at Calcutta as well on the sleep medicine. Now, I know Dr. Nalini very well, and I think the audience also knows her very well. I request her to deliver her talk.
Thank you, sir, for your kind introduction. Can we start the first one? Okay. So, very good evening, everyone, and thank you, Yashoda Hospitals and Dr. Nagarjun, for inviting me to talk with this esteemed audience and speakers. I'm also happy for another thing, that is, in this era of interventional pulmonology, sleep medicine and obstructive sleep apnea have been given so much of importance today. Thank you, Nagarjun, for that. So, we all know that obstructive sleep apnea is a very common sleep disorder. In fact, the second most common sleep disorder, and we see this day in and day out. And the prevalence all over the world is estimated to be about 1 billion. We know that for every case that is diagnosed, there are so many undiagnosed or underdiagnosed cases of sleep apnea. So, when a patient comes to us, we convince them for a polysomnography. Some of them don't get convinced, maybe about 50 to 70% get convinced. We do a polysomnography. Then what do? Depending upon what is it that we look at? We look at the apnea, hypoapnea index. Okay, it is moderate to severe, we prescribe a CPAP. Now, the story begins there, it doesn't end there. Because there might be, we know that CPAP is very effective treatment. Why? Because we have robust data available on the efficacy of CPAP. We also see in our sleep lab, if we do a manual titration, we see that all the events are getting abolished. Okay, so there is evidence, and there is, in reality, we are seeing what is happening. So it should work out, but it doesn't work out like that, because some choose not to use the CPAP. Some find it beneficial, but don't continue because of poor adherence. So there are problems. Now, when the patient doesn't tolerate or doesn't want to use, then as a trial and error method, we try to give other options like surgery or anything, or other options. In fact, there are not many options which we are actively practicing. So this type of therapy of one size fits all, is it correct in this present scenario, wherein precision medicine is being practiced in so many diseases, particularly in pulmonology also. So we need to consider tailor-made treatment. How do we consider tailor-made treatment? By understanding the pathophysiology better. Once we know the pathophysiology, then we will be able to identify the risk, the long-term risk. We can identify the groups which are at very high risk, when we can target them early. And also, for people who don't want to use CPAP, or people who don't use CPAP, who don't tolerate CPAP, we need to give an alternative. So definitely the time has come to think about a non-CPAP therapy. We know the anatomic phenotypes. We know the clinical phenotypes. We know which, right now with advanced literature research, we know which type responds to which type of treatment. But what we don't know is how to identify. That is the most difficult situation right now. The gold standards for identifying the different phenotypes are all done in research labs. Nowadays, people are able to compute based upon the polysomnographic data and tell the phenotypes. And very soon, I think AI-based algorithms will be available for us. But meanwhile, what do? Do we stop or do we go forward? So Nagarjuna has given me a very difficult situation wherein there are no clear data how to clinically identify these phenotypes. So I'm going to talk a little bit on understanding of these phenotypes, and from my knowledge, and also from the knowledge imparted by Dr. Suri, Professor Suri, whom I consider as my mentor. Some of the information I have used from his knowledge bank. I'm going to go forward. So we know that like asthma, like COPD, obstructive sleep apnea is a heterogeneous disease. There are multiple predisposing factors, starting from age, sex, and comorbidities, alcohol, smoking, all these contribute. Now, what we mean by clinical phenotypes, I have divided into 3 groups. One is clinical phenotypes, second is endotypes, third is the polysomnographic phenotypes. What we mean by clinical phenotypes for a disease, like for example, when we say sleep apnea, if people present with similar clinical characteristics, they are grouped into one cluster. So like that, at least 3 to 4 clusters of clinical phenotypes of sleep apnea have been identified. Coming to the endotypes, based upon the genetics or so many other factors, there are certain etiological factors which contribute to sleep apnea. I will go into the details, but there are 4 main mechanisms which contribute to sleep apnea. There are certain polysomnographic phenotypes also. Now what we need to do is link all these things. Can we link endotype to clinical phenotype to polysomnographic phenotype and decide which patient is going to respond to what type of treatment, or what is the risk for this patient if we don't treat? That is what we are trying to look at. Now look at these patients. One is a 38-year-old male, other is 50 years, the third person is 68. All have similar BMI. The first person is actually having a symptom of excessive daytime sleepiness. The second person, woman, is complaining of insomnia and disturbed sleep. The third person is having multiple comorbidities, but not complaining of any symptoms. But his wife says he snores in the nighttime and her sleep is disturbed. Okay, so these are the clinical scenarios. Now, all the 3 patients underwent sleep study, and AHA was found to be 40 for all the 3. All the 3 were advised CPAP. Now, do you think all these groups are going to respond in a similar way to CPAP? And who is going to have more cardiovascular risk? So at the end of my talk, if you understand this, then my purpose is served. So what is it that we look at when we categorize, diagnose, and categorize obstructive sleep apnea? All the diverse polysomnographic data is compressed into one parameter, that is AHI, which is, I feel, too much of oversimplification and which does not do justice to the patient. So look at this here. The study, the epoch that is showing above, you can see that both the studies have, both the epochs have same AHI, similar AHI of about 96. So it's a very severe obstructive sleep apnea as per AHI criteria. But in the first one, you can see that the red lines, those are the apneas. They are very high, and there is significant desaturation. Whereas in the second one, you can see that the pink lines are more. The pink represent what we select as hypoapneas, and the desaturations are not much. So for the same amount of AHI, you see different data and difference in desaturations. So why is it that we need to phenotype these obstructive sleep apnea patients? Once we understand the pathogenesis, we will be able to prognosticate these patients, who is at highest risk, who is at risk for cardiometabolic thing, who is at risk for neurocognitive dysfunction, and we can personalize the treatment. Not only that, we can identify who will not respond to CPAP. That is also very important. So as I mentioned, risk factors are there, clinical phenotypes are there. To very simply say, there are 3 types of clinical phenotypes: those who feel sleepy in the daytime, those who have disturbed sleep in the night, and those who snore and little elderly but don't complain of any symptoms, but they have multiple comorbidities. The endotypes, 4 different types, of course, we'll be describing, and the PSG phenotypes. So the first study, which has looked at clinical clustering of obstructive sleep apnea, was done in Iceland sleep apnea cohort. And they have identified, as I said, 3 groups. The first group is disturbed sleep. We see these patients in our clinical practice also. People won't come with snoring or daytime sleepiness. They come with difficulty sleeping. They say, I have insomnia, or I'm not able to sleep well. And they complain of more of headaches, irritability, and concentration problems, fatigue, increased pain sensitivity, particularly more so in women. This is the disturbed sleep group. The second group is minimally symptomatic. It contributes about 25%. In that cohort, it contributed. These are generally older people. They have multiple comorbidities. They generally say, we do see these patients who come to us and say, "Mujhe kuch nahi hai, madam. I'm all right. My wife got me here." And wife says, "Nahi, madam, he snores a lot, and my sleep is disturbed, and he has all these health problems, and I'm worried." But generally, they say, "I'm all right." The third group is the typical classical obstructive sleep apnea, where they complain of excessive daytime sleepiness. Usually they are younger patients, they are very obese, they have large neck and anatomical factors contributing to their problem. Now, which is the group which is associated with cardiovascular risk? So the literature has shown that excessively sleepy group is the one which has the highest cardiovascular risk. Now, from these clinical phenotypes, what do we understand? One thing is the AHI and symptoms do not track. So AHA might be same in all the 3, but symptoms are different, consequences are different. Now, another important point is the Epworth sleepiness score that we use captures only the excessive sleepy type. The other 2 phenotypes are not captured by this. So if the patient's ESS score is low, don't rule out sleep apnea in these patients thinking that they don't have any daytime thing. In my observation, the ESS score is not very sensitive in predicting the excessively sleepy group also, because we Indians have difficulty in filling up the score, and sometimes though we have certain disabilities in the day, we don't fill up the form, and most of the people, despite symptoms, they give a low score. Now, in the minimally symptomatic group, this group is peculiar that sleep apnea will be diagnosed very late. Most of the time, women are the ones who complain of this, and they are diagnosed late. Now, which group responds better to treatment? Surprisingly, all of them have some effect. Not that CPAP doesn't work in all of them, but the excessively sleepy group is the one which is likely to tolerate the CPAP longer time. Now coming to the polysomnographic phenotypes. So here you can see that, I hope you can see, the pink ones are the hypoapnea events, and you can see that they are more in the supine position. The S that is seen here down is the supine position. So this is a position-related obstructive sleep apnea. Now, this is a very distinct entity which is present in many of the patients, but we tend to prescribe CPAP for all of them. Is it really required? Why is it that positional therapy has not come into vogue or come into fashion? Because of the old-fashioned, archaic, non-aesthetic devices that we advise, like tying a tennis ball to the shirt, which people won't accept. Now we have more advanced technologically devices wherein there's something like a band which can be applied either to the chest or to the neck or to the forehead, and they give some vibrations, and patient is slowly processed to sleep to the side rather than on the back. So this is a distinct phenotype which needs a different type of treatment. Now the second phenotype is REM predominant obstructive sleep apnea. That means we have a clear-cut definition. I'm not going into those details for REM predominant obstructive sleep apnea. So you can see here, these red lines, these are the ones which indicate REM sleep, this one. So you can see that the events are clustered around this REM sleep. So most of the patients with REM predominant obstructive sleep apnea are at risk for hypertension and maybe diabetes, but the research has shown that no increased cardiovascular risk. And in them, one important factor is that to use the CPAP in the later part of the night, because we know that REM sleep comes in the later part, and if they use the CPAP till midnight and then later on patient removes it, then the most part where apneas are going to occur are going to be missed. So another important study, this is an interesting study run by Andre Jinshuk from Yale University, and they looked at various polysomnographic variables, and they tried to differentiate them into mild, moderate, and severe. Here we have in the severe category, hypoxemia and hypoxia, arousal and poor sleep, and combined severe variety. Now we also have here PLMS, that is isolated PLMS. Now what they have found is the cardiovascular outcomes are highest in the hypoxemia and hypoxia, arousal and poor sleep, and combined severe variety. Even PLMS are associated with increased cardiovascular outcomes. So I'm trying to club phenotypes and polysomnographic phenotypes here, clinical and polysomnographic. So if a patient is young, he has excessive daytime sleepiness, obese, large neck, and has a combined severe polysomnographic category or hypopnea-hypoxia category. Basically what we mean by that is multiple and long apneas associated with high desaturations, lot of arousals, long time spent in SpO2 less than 90%. So T90 is like usually more than 25% of the sleep time. That is very important. It's not the number of apneas or hypopneas that count, but the nadir of SpO2 that is reached if it's less than 85%. And if the total time spent less than 90% is high, then these are the people who are at high risk for cardiovascular risk. So as I said, REM-OSA, increased risk of hypertension, but not CAD. However, all these studies are small and they need more validation. One important point here, you find that low AHA is there, but the patient is having nocturnal hypoxia. Then suspect hypoventilation. This patient could be having COPD or something else, neuromuscular problem or something like that. So coming to the endotypes, the traditional thinking is that sleep apnea is because of a small anatomically small pharynx, and we try to overcome that by giving a CPAP. If that doesn't work, then think of other types of things. But that is not the case. We know that there are 4 distinct clinical phenotypes. One is, yes, anatomically small pharynx will be there in most of the cases in varying degrees. Second is the pharyngeal dilator muscles which keep the airway open. They might be impaired. Third, low arousal threshold, and fourth is high loop gain, which are present almost in 1/3 of the cases. Now, I will try to explain this in non-medical terms here, what anatomical defect is. So, now you can see here how the stream is narrowed in the middle, that what we call it as a peak crit. The pressure at which the upper airway collapses and an event occurs is the peak crit. It's very difficult to measure pre-crit in daily practice, but we know from the Starling's equation that There is an upstream pressure, there is a downstream pressure, and when the peak rate is more than the upstream and downstream pressure, that is when a severe anatomic obstruction happens. So what all do we suspect when we think of an anatomic obstruction? It could be because of the small craniofacial abnormalities, wherein the skeleton will be small. It could be retrognathia or micrognathia or something like that. It could be deposition of the fat or extra tissue in the soft tissues, where you can see, in the center. Or sometimes it could just be obesity, not because of deposition in the upper airways, but in obesity what happens is there is increased, reduced extra end expiratory lung volume, reduced FRC. What that does is, whenever the lungs are nicely expanded, your upper airway becomes stiffer. Now when the FRC is reduced, the airway stiffness and length reduces, and that predisposes to sleep apnea. That's a very, very important. Whatever anatomical factors are, if your airway stiffness is good, those people are less prone for sleep apnea. You might be seeing some patients who are extremely obese, but they don't have much sleep apnea. That is because their airway stiffness is good. So airway stiffness gets compromised in obese patients. Now you can see this patient here, lot of apneas in red, almost occupying 30 seconds. The whole epoch is 5 minutes. Now each line you can see, vertical line is 30 seconds, almost 30 seconds with desaturations. We know that there is a significant anatomic component in this PSG phenotype. Look at this obstructive apnea, long apneas. There is so much of desaturation. There may be a component of mixed apnea also. So we know that here the anatomic defect is the predominant phenotype. There's no doubt about it. So can we put everything together? I don't know how far I'm right in this. This is from my own interpretation that I have put this with great difficulty. So whenever there is an anatomic defect, look at the clinical phenotype. How will the clinical phenotype be? BMI will be high, younger age group predominantly, excessive daytime sleepiness will be there, large neck or high Mallampati score, and there might be craniofacial abnormalities. This will be the clinical phenotype. When you look at the polysomnographic phenotype, when anatomic defect is there, we have seen that there are long apneas, severe desaturations, T90 is very high, and another important point, when the peak rate is high, the CPAP requirement is high. Various studies have shown that peak rate of -2 is equivalent to CPAP pressure requirement of 8 centimeters. So if the patient is requiring more than 8 centimeters, there is significant anatomic component. So CPAP requirement will be more than 8. What are the treatment options? We know CPAP is the best treatment for moderate to severe category. If patient has a mild category or moderate category, or patient refuses CPAP or does not tolerate CPAP, then go for other type of treatments. These are specific treatments for anatomic defect endotype. They are oral appliances, orodental appliances, surgery in the form of either you can do a tonsillectomy, UPPP, or a mandibular advancement surgery. You can do a positional therapy. It's very important to do positional therapy in anatomic defect one, because, as I said, in supine position, the airway stiffness reduces, and this will contribute. So a simple positional therapy when patient is not accepting anything also helps in reducing their symptoms and pathophysiology. Weight loss should not be ignored. CPAP and weight loss are very synergistic. Considering if required, a bariatric surgery is very important in these patients. Coming to the risk stratification, as we described, cardiometabolic risk is very high. Low aerosol threshold. We all know these leaves, right? Mimosa, the shy plant, or touch me not. So even with this little bit of touch, there is a response, which we don't expect normally. Normal plants, it doesn't happen. Normal leaves, it doesn't happen. Only in touch me not, it happens. So for some people, what happens is, now before I go for low aerosol threshold, what is aerosol threshold? So whenever there are certain, apneas or hypoapneas happening, there is as a compensation, there is an increased ventilatory drive. This increased ventilatory drive will increase the respiratory effort. So normally there should be a significant rise in ventilatory drive for the apnea to be terminated and for the aerosol to happen. But even before the termination or increased ventilatory drive, the respiratory effort makes the patient awake. Awake in the sense it is an arousal, wherein there is a cortical arousal. That means sleep state changes. So this is called low arousal threshold. That means even with a little disturbance, here the patient is having an arousal. So usually it can terminate apnea and it might help. But if it happens too many times, what happens? Sleep fragmentation, unstable sleep. When there is unstable sleep, when there are too many oscillations, then this will perpetuate the sleep apnea. And this is seen in 30 to 50% of obstructive sleep apnea patients, and it cannot be ignored. So see this epoch here, the pink ones, multiple events, multiple, small, okay, not significant desaturation. This is how a PSG epoch looks in case of low arousal threshold. So if whenever, it is very simple actually, whenever your technician shows you the raw data, just quickly look through, are the apneas very long and significant desaturations, or the HI is high, but the apneas, hypoapneas are very short and no significant desaturation. SpO2 nadir is more than 85%, suspect low arousal threshold phenotype. So what do we do in low arousal threshold? How does the clinical scenario look? Younger patients, more common in women, particularly non-obese, BMI will be less than 32. They usually have either disturbed sleep or insomnia, and they might have some mood changes and fatigue. PSG phenotype, as I said, short apneas or hypopneas. Another important point here, for anatomic defect, we said CPAP requirement is more than 8. Here, usually CPAP requirement will be 8 or less. There are 3 items scoring for identifying this low arousal threshold phenotype on polysomnography. The HA should be less than 30, oxygen nadir should be more than 82.5%, and hypoapnea should be more than 58%. That means these patients are not having, they're getting aroused even before they are developing significant desaturations or long apneas. So that is the meaning there. And typically they have, this is the only group which has a very low CPAP tolerance. And what does it cause in the future? Definitely neurocognitive dysfunction. More than that, we don't know. Coming to high loop gain. So we have finished anatomic defect, we have finished arousal threshold. Now, for a small disturbance, when the response is very high, in Telugu we call it Pavla Sinmaki Rupai action. I hope you understand. So like what they show in Rajnikant movies, maybe you spend 500 rupees for the ticket, but you get the action worth 1,000 rupees. So that is high loop gain. So that means whenever there are events happening, there is a ventilatory disturbance. So the body tries to respond, the respiratory center increases the ventilatory drive. It has to be in proportion to the ventilatory disturbance, or it can be slightly lower. But if it is more, then that is called high loop gain. We have a plant that is the lungs and chest wall. We have the controller, which is the respiratory center. Then we have the circulation, which transmits the signal from the chest and lungs to the respiratory center and stimulates the chemoreceptors. So when there is congestive heart failure, what happens? The circulation gets delayed. So that leads to high loop gain. Also, when some people generally will have high loop gain, so their ventilatory response is exaggerated, more than what is required, and their loop gain will be more than 1. So how do these patients look? Clinically, one thing we can make out when a patient has high loop gain is that their lungs are healthy. Then only the chest wall and everything will dull signals, and the respiratory center will put exaggerated response. They also complain sometimes. These are also not very high, severity cases. Usually BMI will be moderate or less than 32. There is one parameter that they mentioned, how we can diagnose this clinical phenotype. The daytime maximal breath hold. Usually how much time can we hold our breath? Maybe it's up to 60, 90 seconds also sometimes. Here usually it will be around 30 to 32 seconds. This is a surrogate indicator of high loop gain. PSG phenotype, very difficult to say, but sometimes after an apnea, there is too much of increased flow or too much of increased effort seen in the respiratory belt position, chest and abdominal channels. Flow is seen in the flow signal. So if that is there, or if mixed apneas are there, or if this patient with CPAP is going into complex sleep apnea, that is treatment emergent central sleep apneas with a lot of arousals, and generally CPAP pressure is less than 8, that is when we have to suspect high loop gain phenotype. What are the treatment options? CPAP also can help. How does it help? By stabilizing the airway, we can reduce the sleep stage instability. And oxygen. So for the chemoreceptors to sense the rise in PCO2, we also need low oxygen. Then only chemoreceptors will be very sensitive. If you give oxygen, the sensitivity of chemoreceptors reduces. That is how oxygen helps. Acetazolamide, carbon dioxide, dead space, all these, what they do is they reduce the PCO2 and apnea threshold gap. I'm not going into those details, but that is how these things act. And what is the long-term significance? Not very clear, but these patients are likely to go into treatment emergent sleep apneas. See here, you can see after an event, you can see here increased flow, more, and also increased effort associated with arousals. So this is something which can indicate that these patients are likely to go into this thing. I have already covered this. Positional therapy is also important for these patients. Now coming to the fourth one, poor pharyngeal muscle responsiveness. So we know that the British royalty have a lot of power, but they cannot execute it. So it is like that. Upper airway pharyngeal.
Sorry to interrupt, ma'am. We are past time. Please carry forward.
Yeah. So upper airway dilatation is very, very important, dilator muscle activity. And if that is not there, this is how the phenotype. It's very difficult to diagnose this upper airway phenotype, but we can do hypoglossal nerve stimulation, which is available. There are certain tongue exercises and devices to activate the upper airway muscles. Now, so based upon these, so these are the clinical phenotypes. Excessively sleepy group, disturbed sleep, I'll just take 2 minutes, a minimally symptomatic group. And why is it that for the same AHI, patients have different symptoms, different pathophysiology, different responses to treatment, and different risk long-term risk? That is, I think, an area for future research. And one thing we can say is, if a oroappliance device has to be successful, lobe gain has to be low, upper airway collapsibility has to be low. Poor CPAP adherence is associated with low arousal threshold, particularly in low BMI patients. So this is like, a combination therapies are going to be the future, wherein CPAP plus give some zolpidem, or CPAP plus oxygen, or a combination of all the three. So this is one very important slide wherein, upper airway anatomy, these are the treatments, pharyngeal muscles dysfunction, these are the treatments, loop gain those, and low arousal threshold, you give the drugs, which will help in increasing the arousal threshold, but won't affect the upper airway musculature. So a lot of research has been done. We need more validation, but what we really need is clinically applicable tools, which can tell us the type of endotype. Also, we need more biomarkers to identify the future risks. Combination therapy is going to help. If there is a patient with mild upper airway collapsibility with high loop gain and low arousal threshold, oral appliance plus oxygen plus drugs can help. And we have to remember that 70% of the patients will have one of these, phenotypes. Thank you for your patient listening.
So, Dr. Nalini, you have done very well, especially focusing on the phenotypes. As I find that there are some postgraduates also, I would like to share a few of my thoughts, because recently I had the opportunity of addressing this topic at Calcutta, and I am sure the postgraduates will be benefited. Number one, the definition of the snoring is the beating of the soft palate against a closed glottis. That's the simplest thing. And she has very nicely highlighted the EDS, an important symptom. And then I would like to stress one thing. You see, all these polysomnographs and all these things still are confined only to the higher economic strata. In the lower economic strata, where they have got umpteen number of problems, the testing them with PSG is still a dream. So what I would advise, what I suggest, the young physicians to just stress about the pulse oximetry, because thanks to Corona, now pulse oximetry has gained a lot of reputation. Every person has got pulse oximeter, and you tell them to see the pulse oximetry, and as she has very rightly told, less than 90%. In fact, I must say here that less than 85% tissue oxygenation will not be there. So any person can note the pulse oximetry. That's a rough thing. I don't say that it is the main one, but it can substantiate the symptomatology and the examination, which she has very rightly told. And one of the other things is that the snoring can be physiological, especially in children and the menopause persons and elderly age people also. There we have to consider these things and ask ourselves whether it's worth doing polysomnography, or what she has told, positional, an excellent one. Definitely positional one has got a lot of importance. One more thing, as pulmonologists, we are seeing a number of patients having OSA coming to us very late. They have landed in hemiplegia, they have landed in hypertension, they have landed in IHD, and then they're coming to us. What I want to stress here as a teacher, that the OSA can be the starting point for all these things. And the OXA, hypoxia, they are very much interrelated. Now with this thing, I request my co-chairpersons to share their thoughts or wind up the things. And any questions from the audience?
Excellent talk, ma'am. You have taken us in a time travel from AHI to like phenotypes. If anything, AHI will be thanking you right now because you have unburdened the burden of OSA from it. Any questions from the audience? Ma'am will be taking now.
I think it's too much of information in such a short span.
No. You are done very well. The information which you see, everything we cannot give in one session. It is absolutely difficult. The most important things you have given out. And as chairpersons, it's our responsibility to share our experience. That's why I have taken a bit of time.
Madam, I just have one question. I think you have made it as clear as it can be, but have you started using all these things in the clinical practice also?
So I have started
because
looking.
giving a sedative to a person with OSA is something which is little on the riskier side. So we should be very sure whether we're in that particular phenotype or not.
Yes, that's very important.
Is it changing your clinical practice the way you have presented it, and has it come to a stage where everyone can start phenotyping and then start practicing precision therapy in sleep medicine also?
I think we have made the first step, I would say. We have a long way to go. All these can be done only if you have a level 1 polysomnography. Otherwise, no. Because there you have the confidence of looking at the raw data. Now, when somebody is having very low arousal threshold and not very severe sleep apnea, the COMISA, what we call it, insomnia plus obstructive sleep apnea component, definitely I have tried zolpidem in them along with CPAP, and they have done well. That is one thing I have definitely tried. Positional therapy, I'm trying. Rest of the things, not much, to be very frank. But positional therapy and sedatives, we don't have to be so scared of zolpidem and temazepam and all these things, provided sleep apnea is not very severe.
Now, with that context, I also like to share my experience that amitriptyline with CPAP also does well. Amitriptyline, it has got multifarious effects. Number one, it's a muscle relaxant. Number two, it has got, the antidepressant. And then it maintains the REM phase. It doesn't alter the REM phase. So with all these things, yes, zolpidem, otherwise, amitriptyline with CPAP will definitely help.
If you have a very good technician who scores well, then if you know what you look for, what you want to look for, then you won't require much time also. Quickly you can look at the raw data, quickly scan it and find out what you want to look for. It is not very time consuming. Thank you.
Thank you, Dr. Nalini, for the talk. And I think just answering Dr. Nagarjuna's question, actually, lot of times, actually, lot of clinicians tend to stop with AHI. Sometimes if the AHI is mild or normal, then we tend to stop there, lot of times, actually. So as the knowledge is improving, we understand that REM OSA is a different thing. There is increased risk of diabetes and hypertension. And again, positional OSA also. At least for all the youngsters, actually, it's important to just check not the AHI, but what is the REM AHI, what is NREM AHI, whether there is a postural sleep apnea or not. Just don't stop with the AHI. I think that is one thing which we can stress upon at this point of time.
Very easy to look for REM OHA, supino AHI, and low arousal thresholds. Very, very easy. And I think we should start implementing.
Yeah. Thank you.
For the next talk, I would like to invite Dr. Nagarjuna to share his experience regarding precision therapy for severe asthma. I don't think Nagarjuna requires any introduction. It's quite popular and famous across India.
Thank you so much. So this is something which is very close to my heart, and so I have decided to spend a couple of minutes on talking about phenotyping in severe asthma. If I have to say there are any one disease where precision therapy has actually changed clinical practice, that is asthma, other than lung cancer. So in severe asthma, phenotyping has now become the norm. So you cannot decide therapy for patients of severe asthma without phenotyping them. Just the way now for adenocarcinoma, you cannot decide therapy for metastatic ADC without doing the markers. Same thing is true for severe asthma also. I think the slides have to come. So in the next 10-12 minutes, what I would want to do is just answer 3 questions: when to phenotype, how to phenotype, and why to phenotype. And then I'll just briefly share the results from our severe asthma clinic. So the thing is, do we have to phenotype all cases of asthma? Because asthma is the commonest disease which we see in the OPD. So the answer is that no, you don't have to phenotype every person with asthma, only in the step 5. So if the person is not coming under control with medium to high dose ICS plus LABA, only then you have to phenotype. Because in most of the mild to moderate cases, the normal inhalers which we give will suffice. So once you come to severe asthma, then it is essential that you have to phenotype patients, and then you have to start on precision therapy. So this is what I always tell, the 5 steps. So always never forget the basics, confirm. And once you phenotype, you have to decide the therapy accordingly. So the first message I would like to give is that no need to phenotype all cases, though it may be ideal to phenotype, but then it is essential in people with severe asthma. That is, if the person is not controlled in medium to high dose ICS plus LABA, then you definitely have to phenotype these patients. Now, second thing is, yes, you know when to phenotype, then how to phenotype. This is again very important. So as Dr. Nalini Madam also has said, if for every disease you have clinical phenotypes, radiological phenotypes, so on and so forth. So even in asthma also, the, the registries which were there have identified several clinical phenotypes of asthma. Then the most clinically relevant for us is the inflammatory phenotypes. This is what I'll be talking about. You also have pathologic phenotypes. Centers, some centers do endobronchial biopsies for all patients of severe asthma, and then they identify pathologic phenotypes. Then you also have radiologic phenotypes. But all of these are there in data, but what will affect our clinical practice is the inflammatory phenotypes. So broadly speaking, T2 high and T2 low. These are the two broad groups we have to identify first. Then this T2 high is further substratified into 3 groups: the allergic, eosinophilic, and overlap. So our job is to divide the severe asthmatics into either of these 4 groups, either T2 high allergic, T2 high eosinophilic, T2 high overlap, or a T2 low. If we do this, then we can decide which medicine has to be given to whom. Now, how do we identify these phenotypes? Practically, you have to look at 2 things. You have to look at the clinical features, some of the clinical features, and you take the help of biomarkers. So this is where the role of biomarkers in asthma comes in. Now, broadly speaking, if you have to label someone as T2 high severe asthma, what could be the clinical surrogates? One is always ask for the age of onset of symptoms. So if the person has an early onset, that is childhood or the early adult, then it is likely to be a T2 high asthma. Then look for comorbidities. This is second thing which is always important. Focus on the comorbidities. The person has associated allergic comorbidities, then it is more likely to be T2 high. The other clinical surrogate of T2 high is that steroid responsiveness. If you give a short course of steroids, the person becomes better, it is more likely to be T2 high. These are the clinical surrogates. Then biomarkers. Biomarkers always have to be done. The most important biomarker is the blood eosinophil count, which is easily done. So blood eosinophils of more than 150 is considered to be the cutoff, but there are several studies which have used different cutoffs also. Similarly, sputum eosinophils also can be used. The most important thing here is that the person should not be on oral corticosteroids. This is one thing which is important. If the person is on oral steroids, all of these biomarkers can be suppressed. So if the person is on steroids, you try to taper them, stop them, and then redo. Second thing is, it can be repeated on 2 or 3 occasions. What the studies have shown is that if once you get low T2 high markers, you can repeat 2 or 3 times at 1 month interval, and then you see, then majority of them will have elevated markers at some point of time. And the data world over says that up to 80 to 85% of the severe asthmatics are actually T2 high. So only a small subset are T2 low. Now, biomarkers which have been described are these 5: the blood eosinophils, sputum eosinophils, periostin, and lastly IgE. We should understand that elevated IgE does not always make it T2 high. It is the clinical syndrome of atopy plus presence of either specific IgE or SPT. You should prove sensitization. Now, practically what is possible? Blood eosinophil count is possible. Again, most centers are taking so it can be used easily. And the 5th one, that is serum IgE and specific IgA or skin prick testing again is possible. Sputum eosinophils, though it is said in all articles, practically it is not very easy. And periostin levels are also not available for commercial use. So we use a combination of blood eosinophils, and allergen sensitization to determine which phenotype the person falls into. There is a lot of data which has said that sputum eosinophils and blood eosinophils, there is a positive correlation. This is one cohort of asthma people where you can see there is positive correlation, and the blood eosinophil of 220 corresponds to sputum eosinophils of 3%. Similarly, from COPD also there is a positive correlation between sputum and blood eosinophils. So sputum eosinophils are not always essential. You can do away with blood eosinophils also. GINA also says the same thing. To identify T2 high, you need to have blood eosinophils of more than 150, more than 20. If you have sputum, okay, or asthma is clinical allergen driven. This is the 4 important things for identifying T2 high asthma. Now, T2 low is the opposite of T2 high. where you have normal biomarkers. Usually it is late onset. Asthma with obesity is one subtype of T2 low, asthma in smokers, and usually you do not have much of allergic comorbidities. But there is no one particular thing which can always identify the person into one phenotype. Sometimes you look into the whole picture in toto. Once you identify T2 high, the next thing is to identify allergic and eosinophilic. Again, this is very important. So allergic asthma is usually childhood onset. The clinical and the biomarkers, you have lot of allergic comorbidities, usually allergic rhinitis, conjunctivitis and dermatitis. Exacerbations may be there, but not very frequent, and OCS dependency is not very common. Eosinophilic asthma is a very distinct subset, wherein you have late onset, adult onset asthma. Nasal polyps again are a strong pointer towards eosinophilia being the driver, and eosinophilic asthma usually has more frequent exacerbations and more OCS dependence. So these are the clinical surrogates of allergic and eosinophilic, but many times you may not actually pinpoint as to whether it is allergic or eosinophilic, or they may have both features together. Then you call it an overlap phenotype. So eosinophilia, as I have said, is the most important biomarker, and there is enough data which says that higher the eosinophils, more the exacerbations. Higher the eosinophils, poorer the asthma control, and higher eosinophils, lower is the lung function. So elevated blood eosinophils has a significant negative correlation towards asthma parameters. Now, an eosinophilic asthma is very important for us to identify because we have very good biologics which can target this phenotype. So just to summarize, this usually adult onset, not much of clinical allergies, nasal polyps will be there. You have more exacerbations, low lung function. You also tend to have more remodeling of asthma, and you obviously have elevated eosinophils in the peripheral blood and sputum. Now, why is all of these clinical phenotypes so far what I have said also have a dedicated pathway, that is the endotype. So you have separate inflammatory pathways for each of these. I won't go into all of these in detail, but it is suffice for us to understand that allergic asthma is driven by T2 cells, B cells and IgE. Eosinophilic asthma is driven by IL-5 predominantly, and T2 low we have Th17 and other cells for which we don't have any biologic as of now. Again, the endotype is important because you have biologics which target these endotypes. Now, just to summarize, T2 high allergic asthma is usually childhood onset asthma. You have allergic comorbidities, predominantly rhinitis, conjunctivitis, urticaria, and so on and so forth. The patients may give symptoms which occur on exposure to triggers, and you can identify this allergen sensitization. Eosinophilic asthma, again adult onset, more exacerbations, more OCS dependence, nasal polyps, and elevated blood and sputum eosinophils. T2 low asthma, all biomarkers will be normal. It is usually late onset, associated with obesity and in smokers. So this is just a broad overall syndrome, but many times you will have an overlap of these phenotypes also. Now, we have done the phenotyping. Why do we phenotype? Is because in severe asthma now it is the era of biologics. Just like in rheumatology, you have a lot of biologics. We understand that in severe asthma also the concept of one size fits all is no longer valid. So you have to phenotype to decide the next therapy. You don't want to give steroids. So in T2 high phenotype, if you have a T2 high, you have a lot of biologics now which can be tried and which are the first line of therapy. And in T2 low, as of now, we don't have anything as a good biologic, but tezepelumab probably may be coming. As of now, we can offer BT for these people. So in T2 high, again, no biologics. So in India, we have 3 of them now: omalizumab, Mepoli, and Benrali. Most of us must be aware of these medicines. Omali is anti-IgE, Mepoli is anti-IL-5, and Benrali is anti-IL-5 receptor. Now, Dupili and tezepelumab are again 2 biologics which will be launched probably in the next couple of years. And there's one more itepekimab, which is again in the clinical trials. So in the next 2 to 3 years, we'll probably have 5 to 6 biologics in between which we can choose to use. Again, this is something I will just skip through. This is again important. So now it is important for us to phenotype, because if you identify the phenotype and you look for the eligibility criteria, if you have a T2 high allergic phenotype, then you can choose anti-IgE therapy, that is omalizumab, provided the IgE levels are within the therapeutic range and you prove a sensitization. And T2 high eosinophilic, again, this is one of the most severe asthmas which we see. We are lucky enough to have 2 good biologics with us, Mepoli and Benrali, which are anti-IL-5. T2 high overlap, you can use any of these. You have to decide depending on what you feel is the triggering factor. in the overlap phenotype. In T2 low, as of now, we don't have a biologic in India. But in the future, we are likely to have both dupilumab and tezepelumab also. So dupilumab will work in T2 high, eosinophilic, and overlap. And also, there is some data that in T2 low, it can work if it is steroid dependent. And tezepelumab is likely to work across the phenotypes, including T2 low. So this is going to be the biologic algorithm where we can choose amongst the biologics. Now, there are certain therapies which work independent of the phenotype. The one is BT, as I have said, thermoplasty, tezepelumab, and itepekimab. Itepekimab also, if it is through the phase 3 trials, it can be a good biologic for the T2 low phenotypes. So the third message is that it is important to phenotype because you can choose biologics as per the phenotype. As of now, we have only good biologics for T2 high, but in T2 low, we are likely to get good biologics. Now, the last 2 minutes, I will just show our data. So we have been running this severe asthma clinic for the last 1 year at Somajiguda, and we have looked at our data. So this is how the patients come. Patients get referred, they get a unique identity number. We have a counselor who fills the questionnaires and the quality of life scores, checks the inhaler technique at every visit. Then the person goes to the clinician who makes a detailed notes, then a PFT and pheno is performed, and then a final plan is done. And last and most important is we archive the data. So one of the reasons why we have a severe asthma clinic or this clinic is to archive data and generate good data. So we looked at our data of 142 patients, and what we have found is that most of our severe asthmatics are women. Around 70% are women. Most of them are above the age of 25 years. More than 41 is around 70%. So most of them are above 40 by the time they come to us. The age of onset of symptoms below 18, 30%. So it's a varied cohort. You can have different ages of onset. Most of them have asthma which is there for more than 10 years. So by the time they come to us with severe asthma, they have been suffering for almost more than 10 years. Most of them have symptoms significant. Obviously, 80 to 90% of them have the conventional symptoms. Comorbidities, as I have said, the common comorbidities, allergic rhinitis, obesity, OSA, GERD, anxiety, depression. We have questionnaires for each of these. And if you can see the percentages, more than 30 to 40% of all the severe asthmatics have either one or more of these comorbidities. Most of them are obese, overweight, and obese again. Eosinophil count, we have a varied, but less than 150, if you can see, there's only 15% of them. As I have said in the international data also, most of the severe asthmas are actually T2 high severe asthmas. Now, coming to the phenotyping, overall phenotyping, 125 patients, we have the complete data. If you can see, the overlap is the highest group, that is 70 or 125 have overlap phenotype. T2 low is only in 15 of them, which is the smallest cohort. And ABPA, we always screen our patients for ABPA, and we have found a 17% prevalence of ABPA in our cohort of severe asthmatics. So biologics, not everyone goes to a biologic. Most of them, if you do the checklist correctly, majority of severe asthma people actually become better, and we use biologics judiciously. So summarizing our results, most of them have significant comorbidities, and treating these comorbidities will actually make them better. T2 high is the commonest phenotype. 88% of them are actually T2 high. Overlap is the commonest subset of T2 high. If you can see from our cohort, 57% of people are actually overlap phenotype. And ABPA is something which has to be actively screened. 17% of our severe asthma people have ABPA. So phenotyping, just to summarize, phenotyping has to be done in patients of severe asthma. How to phenotype? Use a combination of clinical markers and biomarkers, and choose the biologics based on the phenotype, and then precision medicine, I feel, is the way forward. So with this, I will end by also reminding everyone that this year is going to be the NAPCON year, and next year we'll be hosting NAPCON in Hyderabad. So I think we all should be an active part of NAPCON and dedicate this year to making NAPCON a very fruitful event. Thank you.
Thank you, Dr. You have illustrated your talk very well. Now, I would like to share one thought of mine and then share few things with you. Number one, most of the patients, they feel that the wheeze is more severe than the cough. They do not realize that the cough and the wheeze, they are the two sides of the coin. And there is a term known as the cough variant asthma. So the patients, by and large, They think that a wheeze is more severe. And when you ask them, no, I don't have wheeze. They say that I have only cough. So we'll have to stress this importance about the cough as well. And a few other things, you said the sputum eosinophils, I agree with you. In my long experience, more than 52 years, I have not found, sputum eosinophils in umpteen number of, patients. But seeing the other side, do you advise nasal smear for eosinophils?
No, I don't think there is any data enough for nasal eosinophils. I think it's only sputum eosinophils or blood eosinophils. Sputum eosinophils are supposed to be the ideal or gold standard, but then because it is practically challenging, most centers now prefer to use blood eosinophil as a surrogate for sputum eosinophils.
I agree with you, because there are certain things where nasal smear is asked for the cytology, and they feel that one or two eosinophils, if they are there, they are going to brand it as eosinophilia. And another one thing is that do you recommend allergy testing and the nitrous oxide estimation before recommending this biologicals?
No, see, fractional exhale nitric oxide is not a must to decide on the current biologics which we have. So even if you do not have a pheno, it is not essential that you have to have a pheno to prescribe a biologic. So biologic is prescribed only when the person is not getting better despite the best of the inhalers and treating the comorbidities. And the current biologics which we have in our country are targeting the eosinophils or the IgE. So if you have a good blood eosinophil count, and if you can take a good history and prove allergen sensitization, then you can choose amongst these biologics. But if we get dupilumab is one biologic where pheno is supposed to be a very good surrogate for efficacy. So then I think pheno will have a significant role to play. And for the existing biologics also, elevated pheno is a predictor of response. It is not that if you don't have pheno, you cannot prescribe biologic, but if you have pheno, it will add on to your confidence with which you can say that the biologic will act. So an elevated pheno is also a good good marker for predicting response to both omalizumab and mepolizumab.
I request my co-chairpersons to have any interaction.
Recently, I have come across few patients who do not have any past history of allergies or are not known asthmatics, and they don't have family history also. But post-COVID, they have developed history of allergies, then asthma-like symptoms. So, what is your experience regarding this?
I think that is a very valid point. That many people, not only COVID, we see it post-influenza also. So, any post-viral, you can call it post-viral hyperreactive airway or something like a RADS, which happens, that both influenza and COVID are supposed to incite some sort of bronchial hyperresponsiveness in them. Whether you want to call it an asthma or you want to call it a post-viral reactive airway disease is a different thing altogether. But yes, whatever you said is correct. Many people tend to develop asthma-like syndrome, which I would say is basically bronchial hyperresponsiveness following a severe viral illness.
Nagarjuna, two questions. Can you share your experience regarding switching of biologics in overlap?
Yes, switching of biologics, because of lack of time, I didn't talk about it, but then biologic switch is something which is now accepted. So in overlap phenotype, it is, if you see again in overlap phenotype, to choose whether to go for anti-IgE or anti-IL-5, you have to take a help of your clinical markers. So if the person is having more exacerbations, more OCS use, then I would prefer to use anti-IL-5 biologics because they're better than omalizumab in decreasing exacerbations and decreasing steroid dependency. But at the same time, sometimes you may be wrong in choosing the first biologic. So there is enough data to say that people who fail on omalizumab in overlap phenotype will respond to mepoli. There is also data to say that people who failed mepoli can respond to benrali. So till this much you have strong data. Whether people who fail mepoli will respond to omalizumab is something which we do not have strong data, but omalizumab failures respond to mepoli and benrali. Mepoli failures respond to benrali. Again, this is because benralizumab is a more potent eosinophilic depleter than mepolizumab. So this is what we have as far as biologic switch is concerned. Once dupilumab comes into the picture, then it's going to become more complicated because there is data that people who don't respond to mepoli can respond to dupili. or now people are also trying combination of biologics where they want to target two pathways at the same time. So there is some data on combination of dupilumab plus ipilimumab also. So the future is going to be even more complicated, I will tell.
And one more thing, any experience of anti-IL-5 therapies in ABPA? You have mentioned ABPA also.
I think Inder is also smiling now. So I would not say it is an approved indication as of now, but yes, we have been using it in cases where you have steroid dependent ABPA, or in patients of ABPA who are symptomatic but you cannot give steroids. We have used it in around maybe 10 or 11 patients till now. We have used both Mepoli and Benrali, and I would say that the clinical response is at least reasonably good. But this is only my personal experience. I think now trials are also ongoing wherein people are trying mepolizumab in ABPA.
Now, one of the terms which you used, really I like it. That's oftentimes it's not found in the diagnosis. That is reactive airways. Reactive airways, very rarely I see such a diagnosis. In fact, all of us, we have to remember about this reactive airways. Now, any questions from the audience?
So, how long after optimization with your inhalers are you going for a biologic?
Madam, usually I wait for 2 to 3 months, because after we make any change in the dose of ICS or any change in the inhalers, you should not jump in 1 month or 1.5 months. At least 2 to 3 months is what I would tell, that we have to wait for the change in the medicine to actually have its clinical impact.
Third month we go for
3 months is probably, yes.
Nagarjuna, nice presentation. The endotype that you have described, that's okay, but somewhere possibly there is some autoimmune endotype also to be considered, because we see rheumatoid arthritis in asthma patient, SLE and asthma patients together, and possibly there is some autoimmune endotype also. I don't know.
Sir, maybe it may be there. We're not denying. I think Inder has a comment. In RA, they can have bronchiolitis.
You have bronchiolitis.
I was about to say that.
So that is small airway disease, and sometimes those patients may respond to inhaled bronchodilators. So that is a different thing.
Yeah.
As far as mepolizumab is concerned in ABPA, there are two things: whether ABPA is not controlled or the underlying asthma is not controlled. So if the underlying asthma is not controlled, what we generally do is we tend to increase the inhaler therapy. So ICS LABA, then we go on to tiotropium, then we add other drugs. But ABPA is under control. So ABPA is under control by IG levels which are low. There are no infiltrates, there are no mucus plugging. So we are not worried about ABPA, we are worried about asthma control. And obviously we take care of the comorbid illnesses, because to define severe asthma, you have to take care of the other illnesses. Once we've done all that, if the asthma symptoms are still not controlled, patient still requires steroids because of asthma, then we go on to biologics. On the other hand, there are certain patients of ABPA who are not controlled on medication and are having recurrent exacerbations or recurrent ABPA relapse. So they are the patients where we have tried omalizumab. Some patients have responded to that. Some patients have to be switched over to mepolizumab. So, and that is about 4 or 5 patients, I think, which Dr. Ritesh is treating.
Yeah, I think as far as ABPA is concerned, earlier we have also tried Omali, but the problem with Omali we felt was the dose. Correct.
Yes.
So it will be a very high dose which would be required. So and that had to be given twice in a month. So that is why now, earlier we were giving Omali for refractory ABPA, but nowadays if we have a refractory ABPA, we are preferring to use Mepoli or Benrali. But I would say this is still off-label. We should not be talking too much about this ABPA now.
Hello. Sir, good evening, sir. Sir, good evening,
Yes,
sir.
yes, please.
Should we continue inhalers even after biologicals, sir?
100% yes. So none of them is a replacement to inhaler. Inhalers are the background upon which we add on. So this is always add-on therapy. We're not talking as replacement therapy. So it's always add-on therapy. To the best of my knowledge, there is only one trial where they have weaned off inhalers. That is the dupilumab, and one trial on dupilumab plus ipilimumab. So these are the only two very bold trials where the protocol has actually taken off ICS and taken off LABA. but I would not suggest that we should even tell the patient that the aim of giving a biologic is to get them off inhaler. So first is inhaler, always.
Asthma. And there the pulmonary function test is very important. Closing volume is very important, which we should stress as pulmonologists. So with these few words, and I thank my co-chairpersons also for sharing the session. I thank very much. I wind up the session. I thank the organizers and the audience to have given me this chance. Thank you.
Thank you, sir. Thank you, chairpersons, for hosting the wonderful session. We will now move on to the inauguration of precision clinics. For this, I would like to call upon the stage Dr. Ravi Kiran, sir, the Chief Operating Officer of Yashoda Hospital, High Tech City, to take over this session, please.
All the dignitaries, the faculty, senior members of the management, and the Yashoda family to this academic event. Yashoda has a legacy of more than 30 years. It started its journey in 1989 with a 50-bedded nursing home at Somajiguda. After that, it went on to establish 3 more units. In 1995, Malakpet was established, 2004, Secunderabad, and now in 2022, the high-tech unit. Since inception, it has been focusing on 2 key areas: providing good clinical care through the help of faculty who are pioneers in their field, and also service excellence. Along with healthcare delivery, Yashoda Hospitals has always ensured that there was no compromise in the quality standards. It is one of the first organization to have been NABH accredited in the state. It has also been accredited with Nielsen Best Hospital Award. Now, I would like to talk a little bit about the high-tech unit. It is a 2 million square feet building housing around 2,000 beds. The unique feature about this unit is that there is an integration of nature along with hospital infrastructure. When I say this, I am referring to the provision of around 4,000 square feet in every floor for greenery. The board has ensured that the elements of nature, that is sunlight and air, are really integrated into the stay of the patient and the healing process, for which they have ensured that there is a 1 acre garden in the 7th floor, 1 kilometer walking track in the 5th floor around here, which you people can, during dinner time can walk around this facility. Every room has a large window for sunlight to come in. We have seen, patients feeling really positive when they enter into the rooms. The fresh air which is drawn into the air conditioning system of this unit is also HEPA filtered and pressurized. We have seen that in the recent past, the advances in healthcare have been happening dramatically. Every year, new technology is coming into healthcare delivery. So, Yashoda has ensured that state-of-art technology is present both in the aspects of the biomedical equipment which have been placed in this unit and also into the infrastructure of this facility. When I refer to biomedical equipment, we have the latest Da Vinci Xi system to do robotic procedures. Microscope, one of the most advanced microscope like Kinovo, which is integrated with navigation, which equals to intraoperative MRI. In pulmonology, you people are very well aware. We have one of the first units to have lung point, bronchothermoplasty, BTVA, body box, etc. And last but not least, high-tech unit has got the first installation of MRI-based LINAC. This is an advancement wherein radiotherapy can be given with extreme precision so that injury to the adjacent parts is reduced. So every day MRI is done and the dosage is adjusted according to the changing in the size of the tumor. Coming to the infrastructural aspect, lot of effort and investment has been gone into make this infrastructure patient-centric, like putting escalators at 5 levels, buggies to transport patients across the floors so that the walking effort is reduced. The lifts which have been installed are fire resistant. They can be operated even in the time of fire. The OPDs are in very patient-friendly cluster formation. Each OPD has got its own pharmacy, phlebotomy. Between the OPDs, the non-invasive diagnostic cluster is present so that the patients can easily get their investigations, pharmacy, and exit the hospital. We have a 5,000 square feet dedicated area for health checks, a one-stop solution, and within 3 hours, the patients can get, sorry, I can't call them patients, the people can get their health check done and they can exit the facility. Now, Pulmonary and Critical Care Medicine, Director of Yashoda Hospitals, to come onto the dais. I request Dr. R. Vijay Kumar, Senior Consultant Pulmonologist, to come onto the dais. Dr. R. Vijay Kumar has been Governor of American College of Chest Physician, past President of ISCCM, and is the Organizing Chairman of NAPCON 2023. I would request Dr. Kandis Subhakar to come onto the dais. Sir is Professor and Head Pulmonary Medicine, Kamneni Institute of Medical Sciences. He is the Organizing Secretary of NAPCON 2023. He has drafted the daily regimen for treatment of TB and contributed to standards of TB care in India. He has several publications in national and international journals. I request Dr. G.K. Paramjyoti to please come onto the dais. Sir is Professor and Head of Pulmonary Medicine at Nizam's Institute of Medical Sciences. He has received the prestigious Best Teachers Award for Government of Telangana 2018. He has special interest in biologics in asthma. I request Dr. Sandeep Salvi, Director Chest Research and Training Center, to please come onto the dais. Sir is Chair for Chronic Respiratory Diseases Section, Global Burden of Disease in India. He has more than 200 published papers in peer-reviewed international journals. I request Dr. Indrapal Singh Sehgal, Assistant Professor, Department of Pulmonary Medicine, PGI, Chandigarh, to please come onto the dais. He has more than 140 publications to his credit. He has received ICMR Srimati Kamal Sitpar Award in 2017 for interventional pulmonology. I request Dr. Nagarjuna to please come onto the dais. I would also request Dr. Sunil Vidayat, Unit Head for Yashoda High Tech, to please come onto the dais. Please.
Yeah. Thanks everyone for coming here, and at this junction I would also take it a privilege to talk a bit about the specialty clinic concept in pulmonary medicine. I would say the inspiration comes from my alma mater, PGI, where now the pulmonary medicine has now been subclassified, substratified into diseases, and people now focus on one disease. So you have one consultant for one disease, and I think that is the way it has to be. It has happened in gastroenterology. It has happened in oncology. You know, you have separate oncologists for head and neck, separate oncologists for thoracic. So I think it is the way forward for pulmonology also. So much is happening in pulmonology that it is impossible for anyone to be abreast with any one particular disease, I would say. I think we should all start developing in the future areas of interest or niche areas of interest. And this also improves the patient care. So because in the last 1 year, we have started specialty clinics for 2 diseases, severe asthma and ILD. And what we have seen that people who be enroll into this severe asthma clinic, they go through a very structured protocol, structured pattern, and the results actually improve, and the compliance also becomes better. So the patients do come back more frequently than those who are not enrolled in that clinics. And with this thing in the back of our minds, we decided to expand our specialty clinics to even COPD, which is another disease which is not often focused, COPD and bronchiectasis. So these are the 2 diseases where we thought we should probably put in more effort. And with this, we are starting off in high-tech city also. 4 specialty clinics on 4 different days. So we have 1 day where we want to focus on bronchiectasis, 1 day on COPD, 1 day on asthma, and 1 day on ILD. And then over the years, probably we'll get more people with dedicated areas of interest, and they'll be heading the research in these particular diseases also. And at the same time, we also plan to offer the complete range of diagnostics and therapeutic facilities under one roof. We already have access to most of the diagnostics. We're expanding our PFT services. We have a state-of-the-art pulmonary, the IP suite. And as far as therapeutics is concerned, we are lucky enough to have a very strong pulmonary rehab wing at our center now, and also have access to lung transplant. So the basic aim of these specialty clinics is that I think more centers also should take lead and follow us, and then start this dedicated clinics where you have a structured evaluation of patients and the patient's outcome actually becomes better. So I think this is in brief about the concept of specialty clinics, and I would request Dr. Avikaran to take over.
I think now it is the time to unveil the booklets and posters for the Precision Clinic. I request all the dignitaries on the dais to unveil the poster. Teja.
tried to do is that we have created dedicated proformas for each of these diseases. So each proforma goes for around 8 to 10 pages, and if you do it for once when the person comes to the clinic, I think most of the things which we tend to miss on a daily OPD, I think most of the things are well sorted. I think a structured proforma is one of the most important things when we assess these patients of severe asthma, COPD, ILD or bronchiectasis. I think that is the importance of having these booklets wherein we don't tend to miss anything in your usual OPD rush.
Now, I would like to request Dr. Pavan, sir, to please come and share his thoughts with us.
Thanks, Ravi. Thanks, Nagarjun, and all the entire pulmonary department who has taken a lot of efforts to organize a great session today and like enhancing our knowledge in multiple ways. And we especially thank all these dignitaries, leading luminaries from around the country. As you all know, we are having the NAPCON this year, and I think Hyderabad is getting its due recognition. Thank you, Dr. Vijay Kumar. Thank you, Dr. Shubhakar Kandi, and all the people who put in the efforts. Can you look at the sound? Put in all the efforts to get this NAPCON to Hyderabad. And pulmonary-wise, I think we are doing great. People are thinking because I'm a pulmonary background, I'm favoring pulmonary, but I'm telling that no, we have high quality people here. Nagarjun and our other units, Harikishan and Vishweshwaran and other people too. And we are leading here. And Inderpal, I remember last time was 2 years ago or so, when he was complaining that I had to come to Hyderabad too frequently, too many conferences. So we have designed a room for you also. Here we have a suite room. Right now patients are not full, so we will be delighted to offer it to you. Instead of a hotel, if you want, you can directly come through an airport here and stay in suite rooms, and we'll provide services too. But thanks for all your time though. Yes, as Nagarjuna was telling, there is, as things advance, we have to super specialize. The days of general things, like everything is becoming specialized, and we need to be ahead of the curve, like because there are for the younger upcoming pulmonologists, I see that you have spent time instead of partying somewhere late night also, you are attending conferences. Nobody would have believed us if I told in US, but I think pulmonary is high quality conferences, I think, so you'll go much more enriched. But yes, things have changed a lot. Remember, like I don't think you'll remember, this was 20 years ago when I was doing medicine and all those things. People were saying from a long time. I'm sure like he's up to date now and 20 years ago, and maybe in 20 years also he'll be up to date with the latest in happenings. He'll enlighten you further about. But one thing I urge is, in addition to all the busy practice and all, also you need to know how to succeed in life also. That also you can ask Nagarjun and all, what are the tips if you wanted during dinner and all. But importantly, like we need to, like everything else will follow as long as you get famous. How to get famous is you need to look at the people on stage here and try to emulate their things. And I can guarantee that none of the people are on stage just like that. They put in a lot of efforts, and recognition comes later, but efforts should be from the beginning though. And one other thing is, little underplayed here is research. You need to concentrate a little more on publications. We may think it is super tough to have a publication and all that. Like many times though, it is not what you think. Before going to US and all, I also thought if we need to write some article, publish somewhere, it takes a lot of effort. It'll like multiple days, months, years and all that. So I was never into that. But After going there, I realized one day my professor said, no, you have to have minimum 10 publications. Only after that only we'll allow you to graduate. Otherwise, you cannot graduate from pulmonary. So there was no option. But on the other hand, it's not that tough also, I realized, because one day, just on one day also 3 or 4 publications in chest and all, like what I realized is probably you should have some, if you don't have, anything can be there. If you have some good interesting topics also, it will tend to catch people's attention. So my first case report was in parenthesis, I am Superman hyphen psychiatric psychiatric manifestations of lung cancer. Actually, the patient was having lung cancer with mets in the brain. Every day when I were making rounds with our attending, he used to say, I am Superman, like I'm flying all over the US and all that. So I'm just seeing that, sorry, maybe I quoted the wrong. So I am Superman, parenthesis and hyphen after that is psychiatric manifestations as an initial presentation of lung cancer, like that. There was some popcorn lung, so somebody aspirated popcorn and having like symptoms after 1 month or so. So like in one day I could publish a blood patch pleurodesis, like different treatment for like recurrent pneumothorax or something. So one day I could publish, I written 5 case reports and most were published in chest and also. It is not super complicated also. If you wanted, we can start with case reports and case series and bigger research and all. And if you have any doubts on those things about research, academics, all the luminaries in the city and country are here in the Paul. Does great work in PGI. Dr. Vijay Kumar, as you all know, is here. Dr. Subhakar Kandi, Dr. Panjot, and Dr. Salvi Hyde is doing pioneering work in Pune. So, sir, if you are not fully occupied there, we welcome you to Hyderabad. The only people missing is doing some real research here. So we welcome you also to Hyderabad. So Pune and Hyderabad, there is a competition on best quality of life. So #1 city, some years was in Pune, some years is in Hyderabad, but last 2 years it's Hyderabad though, if you look at the best city to live in India. So I think now Hyderabad is overtaking Pune, so we welcome you to come to Hyderabad also. Okay, anyhow, I'll not take too much of your time. We have a good dinner organized outside too. You can have a look at the hospital and views and all. And most impressive is nobody is outside taking a walk or smoking and all. All of you will do good. I think you're listening patiently and to high quality stuff here. So thank you all. And
thank you very much, sir, for sharing your thoughts with us. With this, now we are going to conclude this session. And now I request Pradeep to take over, sir. We'll close the session. Thank you.
Thank you, sir. Thank you to all the dignitaries. Now, for the next session, may I call upon the dais Dr. Chandana Reddy, ma'am, Senior Consultant Pulmonologist and Intensivist at Star Hospitals, Hyderabad. Dr. K. Bhaskar Kakarla, Associate Professor in Department of Pulmonary Medicine, Nizam Institute of Medical Sciences. Dr. Raju C.H., Senior Consultant Pulmonologist. And Dr. Mohammad Amjad Sharif, Associate Consultant, Department of Pulmonary Medicine, Yashoda Hospital, High Tech City. May I request the chairpersons to call the speakers for the next session?
Good evening, everybody. I will continue the next session. So I really congratulate Dr. Nagarjun and the Yashoda group of hospitals for coming up with this concept. I think it's a really good concept because in the future, I think every specialty of medicine, we need to go into the precision medicine to be able to treat the patients better. So without wasting much time, we'll go on to the next talk, which will be by Dr. Inderpal Singh, who is an associate professor at PGI Chandigarh. He'll be talking about how to identify the cause of bronchiectasis and how to treat it in a more precise manner. Over to you, Dr. Inderpal.
Thank you, Arjun, and thanks for the offer. Although I would disagree with you that Hyderabad is the best place, I would say Chandigarh be done. So, bronchiectasis, as you all know, is abnormal permanent dilatation of the airways. Mind you, it is not a particular disease, rather it is the end stage of lot of things. So bronchiectasis can be a manifestation of many diseases that can come to one's mind, and thus it requires a very practical way and a stepwise approach to actually reach the diagnosis. The diagnosis is important because different etiologies would have different treatment management. So broadly, we classify bronchiectasis as cystic fibrosis related bronchiectasis and non-cystic fibrosis related bronchiectasis depending on the etiology. Why this broad division is there? Because there are certain treatments which are effective only in cystic fibrosis. Why cystic fibrosis? Because it is fairly common in the Western country, the Jewish, and a lot of research has gone into this particular disease as a cause of bronchiectasis. However, other causes of bronchiectasis are also very important and should not be ignored. If you really ask me, the list is exhaustive. So you have primary ciliary dyskinesia, you have immunodeficiencies, you have infections causing bronchiectasis, you have deficiencies, you have genetic disease and whatnot. The list is exhaustive, and unless you are systematic in your approach, you're not going to reach anywhere. So you're not going to tell what your patient is actually having. So when we were residents, we used to treat bronchiectasis as a single disease and give symptomatic treatment to all our patients without knowing what exactly is the cause of bronchiectasis. So why is it really important to investigate cause of bronchiectasis? Because there are certain treatable traits in each patient of bronchiectasis. So for example, if you ask me ABPA, it is treatable. If you don't treat, it is going to progress. Cystic fibrosis again has particular set of treatment that if you don't treat is going to progress. Infection-related bronchiectasis like nocardiosis, like atypical mycobacterial infections, if you don't treat them, they not only are going to progress, but that they can also be life-threatening. Importantly, you can counsel your patients for genetic testing and ask them, it gives them a lot of comfort in knowing what exactly is the disease, whether it is going to progress, what is the prognosis of a disease. And if you give an answer to a patient, it is very comforting to the patient. Recently, I had a patient who kept on asking me questions. How am I going to progress? I have read about bronchiectasis. Why is it there? What is the cause? So when they ask you such questions, you have to give them answers. And the answer is not you have bronchiectasis. The answer is you have bronchiectasis and the cause of bronchiectasis is this. And because this is the cause, your life expectancy is this. And because this is the cause, you are going to follow this treatment protocol that I am going to prescribe you. So that is why it is very important to investigate each and every patient of bronchiectasis. If you ask me how to investigate, well, there is no single protocol that you can follow for each individual. So you have to really pick up which patient would require more extensive investigation, which patient would require just few investigations. But broadly, you have certain investigations that would be there. So importantly, you have to ask what was the age of onset. So if the age of onset of bronchiectasis was since childhood, you would know it is a genetic cause of bronchiectasis and thus would focus more on those aspects rather than other causes like ABP and others. Generally, patients who produce scanty sputum are secondary to mycobacterial, atypical mycobacterial infections or ABPA. So these are two diseases where we generally do not see a lot of expectoration. And if you take proper history, you would invariably reach a diagnosis. So if there is a history of joint pain, joint swelling, you know it could be a connective tissue related disease which could cause bronchiectasis in some patients. If the patient is having GI symptoms, you know that it is inflammatory bowel disease that patient could have, which is causing bronchiectasis. It could be cystic fibrosis that could be causing bronchiectasis. If patients have symptoms of paranasal sinuses, cystic fibrosis, ciliary dyskinesia, and Young syndrome become differential in that. Patients having infertility, again, ciliopathies, cystic fibrosis would be important. So if you properly ask and categorize your patients, most often but not, you would be able to give some answer to your patients. Say, for example, if patient is having yellow nails, you know that the cause of syndrome is yellow nail syndrome. And if patient is having prominent V's, has a background history of asthma, you know that patient might be having ABPA. But obviously, it doesn't stop there. You still have to investigate the patient properly. Imaging is very important. In fact, chest radiograph no longer is the investigation of choice. If you have to diagnose bronchiectasis clinically, HRCT is the way to go. Bronchiectasis is a pathological diagnosis. It's a histopathological diagnosis, but it can be very well picked up by your routine HRCT. The quality of CT has to be good. The features on CT are dilated airways, the dilated bronchi, which should be greater than the surrounding vessel that comes along. So it is called the signet ring sign. There could always be also be a dilated airway which you could see, which is non-tapering, extending distally and peripherally. But certainly there could be indirect signs of bronchiectasis like thickening of the bronchi, like centrilobular nodules, like mosaic perfusion. So these are all indirect signs of bronchiectasis on CT. So like I said, there are certain investigations that should be performed in all your patients. And this is recommended by all the major societies of the world. So this is, first investigation is rule out ABPA. So screen for ABPA. Aspergillus specific IgE is mandatory. A complete hemogram is mandatory. Investigating for mycobacterial and non-mycobacterial infection is mandatory. Measurement of serum immunoglobulin levels is important. And finally, sweat chloride levels, wherever available, should be done. So these are the basic investigations which are recommended by the Society, British Thoracic Society and the American Thoracic Society for at least basic workup of all your patients of bronchiectasis. So if you see one patient of bronchiectasis, at least this should be the first line of investigations that must be sent in all your patients. What we also suggest is that you must also look for Aspergillus fumigatus specific IgG, and this is based on our own experience from PGI, where we found that patients of non-cystic fibrosis bronchiectasis have a very high incidence of colonization with Aspergillus fumigatus, and most of them could behave like chronic pulmonary aspergillosis. In fact, this is really true if you phenotype your patients with post-TB bronchiectasis versus other causes of bronchiectasis. The post-TB bronchiectasis patients behave differently as compared to other causes of non-cystic fibrosis bronchiectasis. Post-TB patients have higher incidence of aspergillus in their airways. They are more likely to present with fungal balls, more likely to present with hemopsis, and more likely to have more exacerbations down the line compared to other causes of bronchiectasis. So we suggest that this investigation should also be done in all your patients of bronchiectasis. Mind you, this is not one-time investigation. You must always follow your patients with repeat testing of Aspergillus specific IgE at least 6 months or 1 year apart, okay? Because Aspergillus sensitization can occur any time during the course of the disease. Once you've done these investigations, what we generally do at our center is we go ahead and do tracheal mucosal biopsy, and we perform electron microscopy in that. Or we have now come up with, we have immunofluorescence antibodies against the ciliary proteins, and if there is a defective ciliary protein, it detects those defects, and you do not require EM for that. What we also do is we also do genetic testing in most of our patients who agree to undergo the test. So over the last 2 years, we have a data of about 300 patients of bronchiectasis who are non-ABP actually, and we've been able to perform genetic testing in about 150 of those patients, and about 50 of our patients have undergone tracheal mucosal biopsies. You must consider bronchoscopy in patients who have a unilateral focal disease to rule out any airway foreign body. So sometimes what we have found is there is a localized bronchiectasis. When we do bronchoscopy, there's a airway foreign body, and once you remove that, patient symptoms generally tend to improve. And also you need to do it to obtain mycobacterial cultures so that you can do rule out mycobacterial and atypical mycobacterial infections. If the patient is having symptoms of joints, always rule out CTD. Always counsel your patient to undergo genetic testing. Okay, it is very important. So why it is important, I will show you. So we all know that there was a big bronchiectasis registry from India, which is the Embark chapter of India, and they had about 2,000, more than 2,000 patients, and across 31 centers in India. And what they found was that post-infective bronchiectasis was the most common cause. Unfortunately, only in about 3.1% of their patients, they could perform all the investigations that are suggested by the British Thoracic Society. And perhaps what we feel is that this may not be a true representation of the cause of bronchiectasis that might be there in India. So we performed this study at our center, and about 454 patients were included in this. And what we found, because we are a referral center, ABPA research focus center, so we had a lot of ABPA. But apart, if you remove the ABPA part, what you see is the idiopathic bronchiectasis label is there only in about 14% of our patients. You see, we've been able to give a diagnosis to almost all our patients because we follow a protocolized algorithm, to rule out or rule in the causes of bronchiectasis. And what we found, what primary ciliary dyskinesia is common, CVID is common in the non-cystic fibrosis related disease. We found cystic fibrosis in about 2 of our patients, and other causes, obviously rheumatoid arthritis and other CTD related disease. So I'll just introduce to you a case. Vinay, a 35-year-old male, came with wheezing, chest tightness, cough, and expectoration. On CT, he had bronchiectasis. And if you see the left pulmonary artery is smaller, there seems to be volume loss on the left side, and there seems to be localized bronchiectasis in the left lower lobe. So what would be your diagnosis? So we would label this case as McLeod syndrome, isn't it? This is what we would do. So because we follow a protocol thing, so as a part of our routine workup for bronchiectasis, we do all these investigations. And we could not find any cause. And then we convinced him somehow that you must go tracheal mucosal biopsy, which he denied. And then subsequently he agreed, and then we did it. We found that he had antibodies missing for the central part of the exoneme. So it was a defect in the ciliary component, the central component, and which we confirmed by the genetic testing, and we found homozygous mutation in this RSPH4 gene. So we conclusively gave him a diagnosis of PCD, primary ciliary dyskinesia, which we would not have been able to give him. We would have labeled him as McLeod syndrome. So why is it important? Because there are certain therapies which might come in future, might have a role in this genetic disease. There may be a genetic therapy for these patients. Importantly, there is a particular diagnosis treatment for PCD, that is long-term azithromycin therapy in the BEST CELIA trial, and has been shown to have good outcomes, reduce the number of exacerbation in patients of primary ciliary disease dyskinesia. So that is why it is important to give your patient a particular diagnosis, and the immunofluorescence has a specificity of 100%. So it will pick up truly all your primary ciliary dyskinesia patients and would miss about 12% of your patients. And we have a lot of antibodies against all the components, ciliary protein components, which can be used. So this is a very good investigation, does not require a very expensive electron microscope. It just requires you to buy antibodies actually. We also perform electron microscopy at our center, and the hallmark of ciliary dyskinesia is absence of outer dynein arm, outer and inner dynein arm defects, and if there is microtubular disorganization and inner dynein arm defects. And in our case, we found this mutation which is known to cause ciliopathy. So the final diagnosis given to our patient was bilateral bronchiectasis, cause of which is primary ciliary dyskinesia, the cause of which is microtubular disorganization as proven by the mutation and as proven by the immunofluorescence technique. On follow-up, he has had one exacerbation. So the treatment, the patient's follow-up is also important. It does not end with one visit. It does not end with diagnosis. You have to follow your patients routinely do sputum cultures at least every 3 months, because if you detect chronic colonization with a particular bug like Pseudomonas, it has prognostic value and you have to eradicate that. So follow-up also is very important. I have certain more, two more interesting cases to show. A 15-year-old male again presented with bronchiectasis. Sorry for the poor image. As you can see, there is diffuse bronchiectasis. Investigations revealed nothing, so we performed sweat chloride. Because this was a young male patient, we suspected cystic fibrosis in him. He was a young individual, so that is why we performed sweat chloride twice. However, we could not find anything in him. What we found was that he had Aspergillus-specific IgEs, which was fairly high, total IgE is fairly high, eosinophil is high, and in fact, he met all the criteria of ABPA. So a young patient with extensive bronchiectasis, meeting all the criteria of ABPA, what diagnosis would you give him? So I would have given him ABPA, right? He has ABPA, he meets all the criteria. The only thing is that in a young individual, if you have such extensive bronchiectasis, it is not explained by ABPA alone. You see, ABPA would take time to go on to that stage, and this kind of disease would be present in patients at a later stage of their life. So we went ahead and did mutation. Mind you, sweat chloride was negative twice, but we still went ahead and did whole exome sequencing, and we found this homozygous mutation in the CFTR gene. So and we were able to give this patient a diagnosis of cystic fibrosis with secondary ABPA. He was started on ICS-LABA and itraconazole and is currently doing well. Another patient with similar presentation, you see this is what I was talking about, a lot of centrilobular nodules, bronchial wall thickening. So these are indirect signs of bronchiectasis. This patient also has in fact, this was the case I presented 2 years back when I came. So, and this has been published. What we found that this patient had sweat chloride elevation twice, you see. So based on this, we could have given her a diagnosis of cystic fibrosis. But when we did the genomic analysis, we did not find any mutation in the cystic fibrosis gene when we did a targeted gene analysis. But still, we had to give her a diagnosis. So we went ahead and did the whole exome sequencing, and we found that she had homozygous mutation in the DNA1 gene, which actually causes primary ciliary dyskinesia. So we were quite perplexed. I mean, we had missed everything. Whether this was true or not, because this was our first patient in whom we had sent genetic mutation analysis. We wanted to confirm it, so we went ahead, did the electron tracheal mucosal biopsy, and proved that this patient had a missing outer dynein arm and gave her a diagnosis of cystic primary ciliary dyskinesia. So you see, this patient had elevated sweat chloride, but turned out to be primary ciliary dyskinesia. The other patient had low sweat chloride, but turned out to be cystic fibrosis. And the take-home point from this is that don't stop prematurely. Always try to go for the nail in the bed. You know, you have to give your patient a diagnosis. Always convince your patient to go ahead in your protocol. Follow the steps. Don't ask for all the investigations at one point. Obviously, the cost is there, but you follow these steps and obviously you would be able to reach a diagnosis. Like I said, the other component of management of patients with bronchiectasis is assessment of severity and treatment. So this is general for all. Use severity index to follow your patient. So give what is the severity when the patient came to you, what happened to the severity after treatment. Generally, do not prescribe inhaled glucocorticoids in patients who do not have an underlying asthma. If they have an underlying asthma, obviously you have to treat that. You must consider bronchodilators in patients who have documented wheeze, okay, and have obstruction on spirometry, and their symptoms would they would have symptomatic improvement once you prescribe them bronchodilators. Chest physiotherapy, mobilization of secretions, use of mucolytic agents is a must for all your patients of bronchiectasis. So this, whatever information is there on this slide, should be done in all your patients, irrespective of the cause. If your patient is having extensive bronchiectasis, this is what you must do. Always vaccinate your patients. We vaccinate our patients every yearly for influenza, and we also vaccinate them for pneumococcus using both Prevenar and pneumococcus 23, given 1 year apart. So Prevenar could be given first or pneumococcus could be given first, but both of them have to be given along with influenza vaccine every year. At least obtain sputum cultures once in a year or every twice in a year, and every time when the patient's symptom worsen, because whatever is the cause of worsening mostly is bacterial or viral, you must treat that infection. And this is the specific treatment for specific cause of bronchiectasis. In ABPA, we generally tend to use systemic glucocorticoids, which are not used in other causes of bronchiectasis, obviously. We also have role of oral antifungal azoles and nebulized amphotericin B. In cystic fibrosis, things have gone very far ahead. Now there are membrane stabilizers, there are replacement therapies, genetic therapies, and we all know that recombinant human dornase is very effective in cystic fibrosis compared to other causes of bronchiectasis. So this therapy can cause harm in other causes of bronchiectasis. So if you use recombinant human dornase alpha in non-CF patients, they tend to have more exacerbation, they tend to worsen more frequently. So don't use this therapy in them. Obviously, if you are able to diagnose immunodeficiency by documenting low immunoglobulin levels, there is a role of monthly replacement therapy with immunoglobulins, and we have few of our patients on monthly replacement therapy. In patients who have neutrophilic dysfunction like chronic granulomatous disease, which can be easily picked up by neutrophil testing, so DHR, dehydroxyreductase reductase test, it can be treated with interferon gamma. PCD, as I told, long-term antibiotic therapy has a role in that. This has been proven by the Best-Celia study, and gene therapy is being explored. So to summarize, bronchiectasis is a chronic progressive disease. It is a end result of many causes, and thus a systematic approach is needed to evaluate all your patients of bronchiectasis. If you get a specific IgE and IgG, sweat chloride, serum immunoglobulin profile, complete hemogram, sputum cultures, mycobacterial cultures, these investigations should be sent in all your patients, okay? All of your patients. Assessment of ciliary dysfunction is helpful if above tests are negative and you suspect that patient might be having some other disease. Say, for example, a young patient comes to you, do not stop at level 3. Go at the next step. An extended panel gene analysis should be performed. The cost of this is not much. When we started doing it, it was about 25,000. Now we've been able to negotiate the pricing to 13,500, which is not much, given the amount of information that we get with this. Thank you very much.
Thank you, Inder, for a very nice lecture on this. Actually, when I was in PGI, I think when we started off around 20 years ago, Dr. Ritesh was the first one to start. We started working on all patients of asthma and worked them for ABPA. A lot of cases are being treated as tuberculosis. So I think we've come a long way from that stage now, and Ritesh has become a pioneer in bronchiectasis and ABPA for sure. So any questions or comments from the audience?
Thank you, sir, for the excellent presentation. There is two comments. According to our observation, we are seeing a particularly middle-aged female patients who develop bronchiectatic patients who develop pulmonary hypertension, hypoxia, pulmonary hypertension, rapidly going down into the right heart failure. In spite of the workup of CTDs, of course, we could not have whole genome sequencing in these patients. But there is one particular subset of patients who go down rapidly due to the hypoxemia. You have any idea about this subset? According to our observation, this is a separate subset.
Most likely it would be what we also see in young females is bilateral middle lobe bronchiectasis. So there is a middle lobe bronchiectasis and lingular bronchiectasis, which we even despite whole exome sequencing. And it is possible that because we are only seeing the exome, there might be a dysfunction in the non-exomic region like intron or the splicing region, where there might be a mutation, because we are not doing an extending whole genome analysis. We are doing a whole exome. So we are only looking at the exomes. And these are the patients whom we have labeled as idiopathic. We don't know what. It is possible that they might have had a viral illness in the childhood and that has left its remnants there. They generally present with non-specific symptoms like hemopsis, but we are yet to see the way that you are saying, sir. We have not seen
Another
such a case.
thing, sir, you have any histopathological studies saying that any intrinsic endothelial disease or pulmonary vascular disease associated with this subset of patients?
I'm afraid we don't have. In fact, we had 2 autopsies wherein we did this extensive workup. The patients died and we did the autopsy. We could not do genetic testing when the patient was alive, but when the patient died, we somehow were able to do it using our own funds, and we could not find anything despite extensive workup, even in a patient who had died. So we had the entire lung to look at, we had the entire vessel to look at. We could not find any cause there.
One more thing. The DPB, diffuse panbronchiolitis criteria, are you using any specific criteria just like it's in Japanese guidelines? Or it is an imaging based?
So it's primarily imaging based. So, and patient symptoms, ruling out all other causes like we do. Once we've ruled all those things, we give a label of diffuse panbronchiolitis in those patients.
Because treatment
Many of these diffuse panbronchiolitis patients might actually have been PCD that we were labeling as DPB, because we have not extensively worked up. But now, because we've been able to work them up extensively, we can definitely say that they are truly DPB.
Thank you.
Good evening, sir.
Yeah, thank you for the very nice talk, Inder. I have one question and one comment actually. So question is basically I would like to know more about the azithromycin therapy which you were mentioning in the primary ciliary dyskinesia, and just incidence. I think I missed it, that less than 10% or something.
No. So that incidence at our center is 10%. 10%. But the study was a randomized trial, multi-center randomized trial, where they have given thrice weekly azithromycin in a dose of 500 milligrams to patients more than 40 kgs for 6 months.
So this is primarily in primary PCD?
Only PCD.
Only PCD.
Only PCD. They had about 300 odd patients in that.
So basically, what was the endpoint like? There was any reduction in severity of symptoms? Or
reduction in the number of exacerbations. During follow-up.
Okay, that is one thing. And so currently, after your talk, I understand that if we are able to do phenotyping, in our setting, basically we'll be able to treat ABPA better, CTD ILDs better, and as you say, PCD better. Because most of the cystic fibrosis therapies are not available to us. Maybe we can just look for other organ involvement or other things like that. So these 3 things.
And also CVID.
CVID.
Cystic fibrosis, I agree that patients, we don't have anything to offer them right now in India, but there are many options for them if they go outside India. Some of your patients might be affordable. So maybe they can send to the cystic fibrosis centers which are giving those patients that therapy. So I don't think we should not be testing them for. So if you send a whole exome panel, you would pick up anything. So if you don't have the facility for sweat chloride, maybe some other center at within your area has that facility, and you can send those patients at least for sweat chloride there. If that also is not possible, you can convince them to undergo a whole exome sequencing.
Yeah, thank you. Thank you, Nir.
This is one last comment. I would like to appreciate the quality of presentation, and this is for everyone here, that Inderpal is, I think, the one of the only few persons who is dedicatedly working on bronchiectasis in our country, and we're lucky to have him talk on his experience on bronchiectasis. And you have any doubts, I think he'll be there for the next couple of hours to clarify the doubts. And I think it was an excellent talk.
Thanks.
On how we can improve our diagnostic ability in this bronchiectasis.
Thank you.
If no more questions are there. Thank you, sir. Thank you very much for your excellent session. Next, I invite Dr. Sandeep Salvi, sir, who doesn't need introduction, is the senior most pulmonologist in the country. He is the director of Chest Research and Training Private Limited, member, board of directors of Gold. He is the chair of Chronic Respiratory Disease Section, Global Burden of the Disease, India. And he has more than 200 published papers in peer-reviewed international journals. And we know a lot of newer areas of research are also, he excels, and it's going to be a feast of knowledge, I think. I hope.
Thank you. Thank you very much for those kind words of introduction. Wish you all a very good evening. At the outset, I would like to express my heartiest congratulations to Dr. Nagarjuna and his team for organizing such a wonderful evening symposium on precision medicine and respiratory diseases. Much needed, need of the hour, and the quality of the faculty has also been absolutely amazing. Thank you for that. I also feel very honored and privileged to be a part of this inaugural symposium in this hall. Perhaps I have been told that this is the first one. So I feel very honored and privileged, and all my best wishes for wonderful academic feasts that will come in this hall for all the years to come. I am going to be talking about phenotyping COPD, why it is important and how do we do that. Chronic obstructive pulmonary disease is currently the second leading cause of death in India. It is also the second leading cause of disability-adjusted life years, which is a combination of suffering and death, both put together. Despite all this, COPD remains a badly neglected disease, not only amongst the patients, but also amongst the healthcare providers themselves. An estimated 50 million people in India have COPD. Around close to 1 million people die every year because of COPD from India. That is about 1/3 of the global COPD deaths. And as a result, a lot of suffering and deaths that are occurring because of COPD is largely because we are not diagnosing and treating it better. If you look at the historical evolution of how COPD evolved, the first clinical description that was given for this disease was by Charles Baden in 1814, when he called this condition as catarrh, which was later translated as chronic bronchitis. And the defining criteria was cough for more than 3 months in a year for at least 2 consecutive years, which was taken up by the Medical Research Council UK as one of the defining criteria for chronic bronchitis. So this was the genesis of how this disease called COPD started. 1821, a few years later, René Laennec, who invented the stethoscope, coined the term emphysema for this lung condition where the lung could not be deflated. After you die, you removed the lung during autopsy and the lung couldn't be deflated. He called it as emphysema. And he showed that through the stethoscope that he invented, that there were presence of reduced breath sounds in this particular condition called emphysema. So the British invented chronic bronchitis, the Americans invented emphysema, and as a result, both of them sort of fought with each other to say that, no, I don't believe in your name, I believe in only my name. The term emphysema was later on found radiologically sometime in around 1895, around early 1990s, where you could see hyperlucent lungs and low flat diaphragms, classically suggestive of COPD. Frank Netter, perhaps one of the best known medical illustrists of all times, he drew this picture way back before the 1960s, where he showed two very classical phenotypes of COPD, the pink puffer and the blue bloater. The pink puffers were what we call as emphysema, and the blue bloaters is what we would call as chronic bronchitis. So chronic bronchitis and emphysema were the two distinct phenotypes of COPD. Mind you that before 1965, apart from emphysema and chronic bronchitis, this disease had a multitude of different names. COLD, COBD, COAD, CAO, NSCPD, so many names, completely causing confusion and chaos in the medical community. But the two large ones, the chronic bronchitis and emphysema, were remained for a long time. And the British and the Americans refused to budge. The British said, no, we will call this disease as chronic bronchitis. The Americans said, no, we will call this disease as emphysema. No question of having any truce between the two. Until 1965, when a wise chest physician called William Briscoe from the United States got the British and the Americans together, and he said, look here guys, because of your fight, this disease is getting a bad name. People are not even realizing what name we should give. Let's give it a common name. So the term COPD was coined in 1965 at the 9th Aspen Lung Conference because of the varied presentation of COPD. So isn't it interesting that COPD is the term that is coined only for the last 50 years or so? It's a relatively young disease. Before that, there were so many names for it. More surprising was the fact that nobody knew what caused COPD until 1970. As late as 1970, people did not know what caused COPD. They believed that it was blowing trumpets, it was being exposed to air pollution, and so many other conditions, so many other causes. When Richard Pito and Charles Fletcher, for the first time, they said that COPD is caused by tobacco smoking. And that shut down the whole history of COPD. Because from 1970 onwards, COPD was a term that was used synonymously with smoker's lung. If you have COPD, it means you have been a smoker. That went on for around 50 years until 2009, when I had this immense privilege to write this review article with Professor Peter Barnes for COPD on never smokers, non-smokers in the Lancet. This is perhaps one of the most highly cited papers in the field of COPD that attracted the attention for the more or less the first time. It had been known for a long time, but nobody gave it more importance, that COPD can occur in non-smokers as well. You don't need to be a smoker to have COPD. And this subsequent follow-up review published in the Lancet Respiratory Medicine just a few months ago, I was fortunate enough to share this with Ian Yang and Christine Jenkins from Australia, where we dug the latest evidence that is available in the field of non-smoking COPD. Now, 55% of global COPD is because of non-smoking causes. That is now well established. In India, 70% of COPD is because of non-smoking causes. And this is based on the Global Burden of Disease 2019 report, which I think is extremely important, because many doctors who still practice, they still have that in their mind that COPD is associated with tobacco smoking. If you're a non-smoker, then COPD is an unlikely diagnosis. Now we know that non-smoking COPD is actually a much bigger problem in our country than tobacco smoking. And this is an article, this is a chapter that I wrote in the Encyclopedia of Respiratory Medicine, where non-tobacco smoking COPD has gone on the top. And even within that, there are two categories: exposure to other noxious stimuli, be it ambient air pollution, be it household air pollution, be it occupational exposures. But again, you don't need to be exposed to air pollution to develop COPD. The non-exposure to noxious stimuli risk factors include poor lung growth during childhood due to poor nutrition, recurrent respiratory tract infections during childhood, poorly treated chronic asthma, and then TB-associated COPD. All of this can be associated with COPD. Why that? Even if you look at tobacco smoking COPD, cigarette smoking, bedi smoking, hookah smoking, chillum smoking, all of them are also associated with COPD. And I believe that each one of them is likely producing a different phenotype of COPD. So these are all the different phenotypes of COPD that we currently know of that are associated with increased risk of developing COPD. Is non-smoking COPD similar to or different than smoker COPD? This was a research study that we conducted with the Imperial College London with Professor Peter Barnes, and we found some very interesting differences. Non-smoking COPD predominantly occurs in females, occurs in younger age people, less than 40 years. They have more small airways obstruction. If you look at the oscillometry parameters, non-smoking COPD has predominant small airways obstruction. And if you look at the high-resolution CT scan images, then you find predominant emphysema in tobacco smoking COPD, but you hardly find any emphysema in non-tobacco smoking COPD. And also in HRCT, you see classical signs suggestive of small airways obstruction. So we are now seeing phenotypic differences between smoking COPD and non-smoking COPD. This is a preliminary report of a very large study that we are doing nationwide among patients who suffered with pulmonary tuberculosis, declared as cured. They have completed their treatment, but they keep on coming to the outpatient department with symptoms of cough and breathlessness. When we do spirometry in these patients, both pre and post bronchodilator, we found something very amazing. 54% of these patients show classical spirometry evidence of COPD. Now this COPD that is associated with tuberculosis is now called as TOPD, but look at the prevalence, 54%. In fact, only 11% of these patients have normal spirometry. 26% have preserved ratio impaired spirometry, half of whom will develop COPD in the next 5 years, and then around 9% have asthma. Now, so TB doesn't end after you have stopped the treatment and the patient is declared cured. Actually, a lot of things start happening after that. COPD is one of those common diseases that has not received the recognition that it deserves. So TB-associated COPD is at a different phenotype. How do we treat it? Should we treat it with bronchodilators? Should we treat it with inhaled corticosteroids? Should we treat it with triple drug combinations? The answer for that is still not yet known. Now, we have been trying to phenotype obstructive airway diseases for a long time. And here is the old classification of asthma: atopic asthma, non-atopic asthma, emphysema, chronic bronchitis for COPD. And then over the years, all these wonderful images have evolved in textbooks and medical articles that keep on telling you the different phenotypes of COPD. Has that got translated into clinical practice over all these years? Sadly, no, because the treatment hasn't changed, depending whether you belong to whichever phenotype. Now, the GOLD 2023 report classically has changed the definition of COPD. It has called COPD as a complex and a heterogeneous disease, which means that it is not one single disease. It is a multitude of different things that are associated with disease. Airflow obstruction is only one component of the disease. There are many facets to COPD, and these vary from person to person. And here is the beginning of phenotyping, the need to phenotype these patients of COPD, and the realization that one size does not fit all. So the same standard treatment for COPD cannot be given to each and every patient. Vanessa MacDonald, who was a research nurse working in Australia, published this very interesting paper, Multi-Dimensional Assessment of Older People with Asthma and COPD, Clinical Management and Health Status. What she did was, she looked at these patients of asthma and COPD from a multi-dimensional perspective by administering questionnaires, doing a clinical examination, physiological measurements, and other biomarkers. And what she found was something very interesting, that most of these patients of COPD, they have multiple traits that need to be individually treated. Most common amongst these were activity limitations, was seen in 74%, systemic inflammation in 60%, and deficits in area of self-management skills. These were the main issues that the patients were worried about. Doctors never addressed these issues. Doctors were only addressing the issue of what is the FEV1, what is the FVC, what is the ratio, and so on. So clearly there were at least 4 treatable traits per patient that required non-pharmacological intervention. And obviously, most of these traits were not correlating well with the traditional spirometric index that we have been using all these years. So she shook the world and said, hey, stop looking at COPD only from a spirometry perspective. There are so many other perspectives to COPD that you need to start thinking about. And then she said, let me do a clinical trial. This was a randomized controlled trial where she separated these 55 COPD patients, patients who were above the age of 55, into two groups. One receiving the usual care, the gold criteria, gold guidelines COPD care, and the second was multidimensional care assessment, where personalized care plan was offered to each of those COPD patients. And here is the bottom line. Just look at the graph over here. Look at the difference in the quality of life as assessed by the St. George's Respiratory Questionnaire. Amazing results. The number needed to treat was only 2 patients to achieve a clinically significant change in SGRQ, which meant that if you treat your patient of COPD according to the gold guidelines, well, it does help. But if you treat the patient as an individual from a personalized care plan, that offers a lot more to that patient. The quality of life gets much, much better. So this was the beginning of what we call as treatable traits or individualizing treatment for COPD. And I've just underlined that. Multidimensional assessment and tailored interventions for COPD, respiratory utopia or common sense. I think it all boils down to common sense at the end of the day. Because patients of COPD have such variable traits that we need to now start looking at each of those, identify those traits that are treatable, and then individualize treatment for each of those traits. This is a wonderful review article published by Alvar Agasti in the European Respiratory Journal in 2016. Look what he talks about. Pulmonary treatable traits in the first column, then diagnosis, how do you diagnose each of those traits, the importance of each of those traits for the patient as well as for the doctor, is it easy to recognize these traits, and how do you treat each of these traits? I thought this was brilliant because you go into the deeper portion of individualizing treatment for COPD, airflow limitation, eosinophilic airway inflammation, chronic bronchitis, airway bacterial colonization, chronic respiratory failure, pulmonary hypertension, presence of cardiovascular disease, presence of depression, anxiety, airway bacterial colonization, deconditioning, a whole host of all this. There are 3 slides that I'm showing you how you can include the traits of your COPD patient, categorize them into treatable and non-treatable traits, how to diagnose each of those traits, and then treat them accordingly. So I think this is the beginning of how COPD management is now going to take place. And there are a large number of studies that have been published over the last few years that specifically talk about treatable traits in COPD and how you should manage and individualize and personalize pharmacotherapy and other non-pharmacological treatments for patients of COPD. Here is a very interesting study that was published just last year. Treatable traits most substantially associated with poor health-related outcomes. And look at the ones that are full in orange. Those are the ones that are most common. So frequent chest infections, dysfunctional breathing, inadequate inhaler technique, systemic inflammation, depression, pathologic colonization, and so on. These are the top ones. These have actually never been addressed in real life. There is a phenotype of COPD who do not know how to take their inhaler devices correctly. You call that as a treatable trait. It's important to classify them because otherwise you take it for granted that whenever you write an inhaler, patient is going to use that correctly. Just want to show you some snippets about what is likely to happen in the future in this field. So pathogen colonization, frequent chest infections is something which is quite common in patients of COPD. One of my PhD students actually did microbiome assay in the induced sputum of patients who were suffering from COPD and compared that with healthy individuals. What she found was quite obvious over there. Patients who have COPD have large number of bacteria compared to those who are healthy. If you look at pathogenic bacteria, such as Streptococcus pneumoniae, Moraxella catarrhalis, or H. influenza, or Pseudomonas, these bacteria are present in abundance in the airways of COPD patients, even when they have stable disease. So you can see here, healthy non-smoker, healthy smoker. Then you have the healthy biomass. So they're the ones who have normal lung function. And then the last two are the ones who have COPD. Tobacco smoke COPD and biomass smoke COPD. Look at the leap in the amount of bacteria present in the pathogenic bacteria present in the airways. We then went on to find out why are the airways flooded with pathogenic bacteria in patients of COPD even when they are in a stable condition. What is it that is responsible? So we collected peripheral blood monocytes from the vein. We converted them into macrophages and fed them with these pathogenic bacteria to look at the phagocytic activity of these monocyte-derived macrophages. And what we found is in that last column over here, patients of COPD have defective phagocytosis. Their macrophages are incapable of going and eating up these bacteria that are present in the airways. And that is the reason why they're getting flooded with bacteria. And they just need to go a little bit above, just cross the tip, and then they start getting acute exacerbations. To take this story further, we actually dug deeper into why do they have a defective phagocytosis. And the answer that we found was these macrophages are unable to utilize glucose. The glucose is entering inside the cell, but this glucose just cannot be metabolized. And therefore, because of that defect in glucose metabolization, they are unable to phagocytose. We collected peripheral blood from asthmatic patients and COPD patients and looked at the enzyme that is associated with glucose utilization, GAPDH. And you can see a wonderful difference over here. Very poor enzymatic activity in COPD patients compared to asthma. Then we thought maybe this is a good blood test that differentiates between asthma and COPD. We even patented this idea. It's still under the patent process. But the bottom line is, all those harmful pollutants that you inhale, they damage the metabolism of the cells systemically, not only in the lungs, but systemically. Can you reverse it back? Here are the potential answers that most of the literature has suggested. Metformin, which is used for treatment of diabetes, N-acetylcysteine, which is widely used, melatonin, which is one of the best mitochondrial antioxidants, and garlic extracts have been shown to reverse this process of a systemic defect in phagocytosis. So the last slide that I wanted to share with you is future management of COPD will likely be based on patients' most important concerns. What is the patient mostly worried about? Forget his FEV1, forget his FVC, forget his DLCO values, forget his other parameters. Mr. Rao, what bothers you the most about your COPD? That's the only question that the doctor should ask. And if the patient answers, I don't want to die soon, then the pharmacotherapy changes. How does the pharmacotherapy change? Good, appropriate pharmacotherapy, make sure that the patient is adhering to treatment, because that has been shown to improve survival in the GOLD 2023 report. Pulmonary rehabilitation and long-term oxygen therapy, they have all been shown to improve survival. So if that is the concern of your COPD patient, that should be the treatment. If the patient says, my cough and phlegm are bothering me more than anything, how should I treat it? Long-acting bronchodilators, N-acetylcysteine, roflumilast are the 3 drugs that you should prescribe for this patient. If he says, I feel very short of breath and find it difficult to breathe at times, breathlessness is a main concern of this patient. Bronchodilators, theophylline, pulmonary rehabilitation. You should focus your treatment on these conditions. I do not want to go back to the hospital for another exacerbation. Doctor, please prevent me from getting my next exacerbation. What can you do? Vaccination, 5 vaccines, influenza, pneumococcal, herpes, DPT, and the COVID vaccine. 5 vaccines should be given to every patient of COPD. N-acetylcysteine has been shown to reduce COPD exacerbations. Inhaled corticosteroids and pulmonary rehabilitation have been shown to reduce COPD exacerbations. If the patient says, doctor, my cardiologist tells me that my COPD is responsible for the heart failure, and this is worrying me, do something about it. Do not deny this patient a beta blocker. Continue with the bronchodilators, but make sure that you as a pulmonologist is not denying this patient beta blockers, because that is going to increase his survival than anything else. If the patient says, my only desire is to drop my grandson to the bus and bring him back on his return, I only want that in life, doctor. Please help me do that. Pharmacotherapy, palliative care, and counseling is what you should be offering to this patient. So look at the individualizing of the treatment of COPD based on what is the most important cause of concern for this patient. And I believe that this is going to keep on expanding with time, and this is going to be the future of treating COPD. Thank you. Thank you very much.
Again, this is an excellent presentation, especially the final thing, what patient says and what we have to deliver. There are one or two comments, sir. One phenomena that macrophage activation or inefficiency of the clearance. The other side of the coin, which I have gone through the literature, is that is the neutrophilic elastase, which will prevent the opsonization of the. Probably in future, we may have a balance between the either in avoiding the neutrophilic elastase activity, thereby increasing the macrophage. Probably this is the balance which we need to achieve, act as a therapeutic one point. The second thing is, the problem is with the rapid advancement of the imaging and functional studies, we are seeing more and more small airway disease cases. But the really worrying thing is, we are getting the diagnosis. What about the therapeutics? So this is the worrying thing. How much drug we are going to give the patient is really reaching the needed airways, and at which point of the time we can easily diagnose the earliest point where the tidal volume is going to get compromised so that the future progression of the disease can be achieved.
I think
so
two excellent points, absolutely brilliant. So immunometabolism is the metabolic activity of the immune cells, and how that gets hampered in patients of COPD is a very big area for research now. Because if you know answers to that, you can prevent a lot of damage that is occurring in the lung. So not only for macrophages, but even for neutrophil elastase, as you very rightly said. It's also very true. And second, very important point again, small airways. Are we targeting small airways in patients of COPD with the drugs? Are these drugs reaching the terminal, the small airways, to cause any effect? I think that's the future. I mean, because we don't have ultrafine particles, there's only one that I know of that is currently available, which is beclomethasone and formoterol in ultrafine combination. That is the only drug that has ultrafine size to reach the small airways. But I think as technology will get better, as we can manufacture drugs with ultrafine particles, maybe we can treat COPD patients a lot better than what we are doing today.
Any questions from the audience?
Regarding tobacco smoke-related COPDs. Regarding tobacco smoke-related COPDs, here in South India, I have come across few COPD patients who inhale snuff. It is not smoke. They directly inhale through nose tobacco powder. I don't know about North India and Central India, but here in South India, I have come across quite a good case, quite good number of cases with severe COPDs.
Oh.
And they suffer like anything, and we routinely ask, do you smoke? No. Any other exposure of smoke? No. Biomass exposure? No. Any chemical factory? No. But ultimately, I have made it a routine in middle class people asking, because 4 cases I remember, we were 2 females and 2 males. With great difficulty, they came out that they inhaled snuff for more than 20 years.
No, very interesting points. I mean, this is, I think, an important cause of COPD. If at all you have got a good series of cases, you must publish that, sir, because the world is not aware about it.
Dr. Salvi, I really compliment your talk. I just want to share one thing as a medical teacher for the last several years. In fact, one of the things which you brought out is the breath sounds. In the emphysema, the breath sounds are diminished vesicular breath sounds with prolonged expiration. And unfortunately, I'm not seeing these things in the present, medical, technology or whatever it is. Everybody is interested in the technology, but they're forgetting the basic things. And another thing is that, clinically what we can differentiate between the emphysema and the chronic bronchitis is one term known as augmented breathing.
Oh.
Yes, if you ask the patient to breathe fast, in the chronic bronchitis, the breath sounds will be heard. Whereas in emphysema, because of the cutoff of the peripheral airways, the breath sounds will not be heard. because there are a number of, the postgraduate students are here. I just want to share this thing. This is one of the important things clinically when we put our stethoscope. In fact, the pulmonologists, they're not using their, stethoscopes properly, which I would dare say. Because everybody is interested to see the chest X-ray first, or then go for CT chest, hardly using their Linac tubes. So one of the things which we can differentiate at the bedside itself, augmented breathing.
So amazing, sir. Thank you so much, sir.
Thank you very much, sir. Apart from this, I would be happy to share that, we are the first unit to be doing this BTVA procedures for the severe COPD. And the next talk, I would like to invite Dr. Raghavra sir, consultant pulmonologist at AAG Hospitals, Hyderabad, for his talk on interstitial lung diseases, importance of getting the diagnosis correct.
A very good evening, and I'm really thankful for this opportunity to talk here in front of all the dignitaries, my senior teachers, professors, and colleagues. My topic would be basically to bring this diagnosis of interstitial lung disease and getting it in the area of precision medicine. Agenda would basically to go through the history and conceptualization of ILD, which has happened over the last 2 decades through previous centuries, and need for correct, not only diagnosing them, also the need for correct diagnosis and clinical tests which we use for confirming the diagnosis. And are we at a time where we can really split or lump them according to the ILDs, and where precision therapy is at present? Coming to the history, as in COPD, it has gone through a lot of tumultuous terms. Initially described way back in early 18th century, a classical description of hypersensitivity pneumonitis was given. Then the description of cirrhosis of lungs was given, and this, with the advent of technology, with the advent of understanding, with the advent in pathology, we moved to the pathological description of UIP in early 1960s, and in 2000 we had a definition for IPF. And the amount of research that has gone through has significantly increased. What has happened in the last 2 decades is much more compared to what has happened in the last couple of centuries. Again, the description terminology has changed a lot, from Hammond-Ridge syndrome to cryptogenic fibrosing alveolitis to idiopathic pulmonary fibrosis. And we are all very well aware with the classification of ILDs, which broadly are grouped into those of known and unknown causes, all the unknown causes being grouped into idiopathic interstitial pneumonias, and those of known causes to granulomatous diseases related to drug exposures, those related to CTD ILDs, and other rare ILDs like cystic ILDs. So yes, we need to diagnose them, and diagnosing them correctly is of very prime importance. The need for accurate diagnosis entails us to understand the nature of disease, treatment options which we can provide, and obviously the way we can prognosticate our patients. ILDs broadly, when we try to understand them, the nature of disease, some of them are just reversible and self-limited. Just removing the inciting agent would halt the ILD, like in respiratory bronchiolitis ILD. Sarcoidosis is another ILD where a subset would probably really not need any treatment, and simple observation is sufficient. Then we have a subset of ILDs where they are reversible, but they have a risk of progression when they're not treated or they're undertreated, like organizing pneumonia, NSIP, and DIP. Then we have some ILDs which are stable and they have a residual disease after getting treated. Some of them which are progressive, irreversible, but still have a definitive potential for stabilization. All the fibrotic NSIPs, hypersensitivity pneumonitis, and the subsets of CTD ILDs, sarcoidosis would come under these, wherein they can be stable with residual disease after treatment, or they could be progressive, irreversible, but still have a potential for stabilization. And we still might encounter a subset where it might be progressive, irreversible despite therapy, the classical description of IPF. And yes, this leads us to prognostication of his ILDs, and prognostication classically is done comparing them to interstitial IPF. The median survival is classically described to be less than 5 years, and for the other ILDs like NSIP, 5-year survival rate is 82%. Still, after extensive diagnosis, biopsy, and in large volume centers wherein ILD is dealt with, we still end up having unclassifiable ILDs after MDDs also to the tune of 10 to 12%. Here again, these unclassifiable ILDs have a mortality of nearly 30% at 5 years. CTD ILDs, the most common CTD ILDs which we encounter being rheumatoid and systemic sclerosis, median survival would vary upon the pattern of ILD we encounter. Pattern of ILD with so like NSIP or UIP, NSIP has a much better survival of nearly 15 years compared to a UIP pattern of ILD having a survival of 3 years with systemic sclerosis. Of all these, probably fibrotic hypersensitivity pneumonitis has been described to be as bad as IPF in terms of median survival, though at present it might behave as a progressive ILD, which is probably not responding to treatment. We do notice like after treating them, they tend to stabilize. And sarcoidosis, eventually 20% of them go to stage 4, and the 10-year mortality in sarcoidosis ranges to the extent of 16%, but this is all-cause mortality, not only complications related to pulmonary etiologies. Then we often encounter this new term of interstitial lung abnormalities. And a CT scan which we obtain for some other causes, like a routine screening CT for CL lung or an abdominal CT, where we find subtle reticular opacities. We are labeling these as interstitial lung abnormalities. And these interstitial lung abnormalities, when we are following them up, the risk of progression is 40%. To put it the other way, they don't progress in nearly 60% of patients. But these have been shown to have an independent risk of mortality. So these things have shifted, have caused a shift in our conceptual thinking, whether to phenotype them to the progressive fibrosing ILDs, or even the conceptual thinking has shifted in the classification of hypersensitivity pneumonitis from acute, subacute, chronic to fibrotic and non-fibrotic ILDs. This basically happened with the recent landmark trials which we encountered in last 4 or 5 years, beginning with the Senesis trial in systemic sclerosis, inbuilt with nintedanib in progressive pulmonary fibrosis. Both of them have shown to decrease the annual decline in FVC. The inbuilt trial probably has the most robust data of these progressive pulmonary fibrosis and utility of antifibrotics, wherein 5 different subclasses were treated with nintedanib. Pirfenidone has less robust data when compared to nintedanib over here, but the trials wherein pirfenidone was used, especially the relief trial, was prematurely terminated because of slow recruitment rate. Of course, inbuilt trial, which is giving us the most robust data, has its own backdrops, wherein if we actually go through them, the decline in FVC was primarily driven by the UIP pattern on radiology when compared to the non-UIP pattern, and almost 25% of these progressive pulmonary fibrosis in inbuilt trial were CTD-related ILDs, and they were receiving treatment in background. And this treatment was with DMARDs. These themselves can decline the annual decline in FVC. So with this, we can probably say there's a need for individualization in ILDs that is beyond the etiological diagnosis. And this has led to the new definition of progressive pulmonary fibrosis, which has been endorsed by the recent ATS guidelines, wherein in a patient of known ILD, of an unknown etiology other than IPF, we need at least 2 of the following 3 criteria with no other alternative explanation, that being worsening respiratory symptoms, a physiological evidence of disease progression by an absolute decline in FVC by 5% or DLCO by 10% at 1 year, and with radiological evidence of disease progression. And the same paper also gives us the proportion of ILDs wherein there can be a progressive pulmonary fibrosis, which they have represented by the blue shaded area. Literally all of them have a potential to be progressive pulmonary fibrosis. The maximum one with the RA systemic sclerosis ILD is hypersensitivity pneumonitis. So a position paper statement actually allows us or helps us understand, like when people are being followed up, when they're not being treated initially as in the unclassifiable ILDs, they have a progressive disease, we can offer them antifibrotics. Or those who are being under optimal treatment and still we have evidence of disease progression, we can still consider adding an antifibrotic therapy. So to understand the evolution of treatment, Initially, way back in 1960s, 70s, it was of a notion that steroids have to be used in every ILD. Then, after the position statement wherein IPF was described, again, adding azathioprine to prednisolone apparently was shown to be beneficial in this group of IPF patients in an RCT. Then came the landmark trial of Panther IPF trial, wherein additional immunosuppression has actually shown to be harmful rather than beneficial, and hence came up the concept of IPF versus non-IPF, wherein we use it's steroids versus non-steroids. And in the meantime, we also had other drugs like pirfenidone and nintedanib, which came up, the capacity and impulses trials, which definitely showed there is a slower decline in annual FVC, and probably the only therapy which we are offering are IPF patients. Then came up the inbuilt relief and senesis trial of this phenotypic classification, wherein we can now we are having a debate of steroids versus antifibrotics versus immunomodulation and antifibrotics. To add to this, there are few cluster analysis reports wherein we are trying to classify or cluster phenotype IL progressive pulmonary fibrosis, wherein a retrospective analysis of diagnosed pulmonary fibrosis, progressive pulmonary fibrosis, have been shown to have a detrimental effect with steroids. This is apart from those who have been classified with IPF. And the clinical tests to confirm diagnosis of ILD is basically our HRCT scan, serological markers. The role of hypersensitivity pneumonitis antigen panel is really very debatable. Maybe the other way around, when we have a diagnosed case of hypersensitivity pneumonitis and we don't know what exactly is the inciting agent, getting a hypersensitivity pneumonitis antigen panel might actually help us, and if feasible, should we try to eliminate exposure to the antigen. BAL again has very limited role. Probably a lymphocytic BAL can help us differentiate HP and IPF. Lung biopsy from the traditional transbronchial lung biopsy again has a very limited role, probably would help us with sarcoidosis, hypersensitivity pneumonitis, and maybe when lymphangitis is a differential. And now there is an increased approach of using cryo-TBLB and surgical lung biopsies. Cryo-TBLB, after complete biopsy and multidisciplinary discussions, we might end up reaching a diagnosis of around 80% compared to surgical lung biopsy of 90%. So with all this, probably we are at a point where we are trying to lump diseases, lump the group of ILDs which are progressively, have a progressive nature in spite of treatment. But shifting from this concept of splitting to lumping should be complementary rather than to each other, and should be a stepwise approach. Though when we are actually encountering ILD in an early stage, it is still very wise for us to split them, get a defined diagnosis. When these disease-specific approaches in major subgroup are failed, like they are failing to prevent progression or fibrosis has advanced, that is when we need to probably lump these. And this concept of lumping is basically after understanding of the different pathobiological mechanisms. The end stage fibrosis is probably mediated by multiple molecular mechanisms which may not be similar in each ILDs. And this very understanding that this may be mediated by different molecular mechanisms is wherein we have a role of precision therapy. In a simpler way for us to understand, probably every ILD which can be treated with steroids will not need a second agent like mycophenolate, and every ILD where we see fibrosis on a CT scan wouldn't need antifibrotics. So coming to the role of precision therapy after going through all this, it's basically a huge conceptual shift for us to implement in our clinical practice with ILDs, and with large-scale sequencing platforms, bioinformatics analysis. The best role of a precision therapy in ILD is elucidated from this role of N-acetylcysteine, which is a post-hoc analysis of the Panther IPF trial, wherein a single gene polymorphism in the TOLIP gene with a TT nucleotide genotype has actually been shown to be beneficial, improving the end primary composite outpoint compared to the CC genotype, where it was harmful. Based on this study, we actually there is a double RCT which is going on with this, wherein N-acetylcysteine is being used in people who have this specific mutation, single gene polymorphism in the TOLIP gene. The next best application of precision therapy in ILD as to date is with the Beresite NVISA genomic classifier, which is a complete RNA transcriptome analysis, which is machine driven, which has been developed on the lung biopsies which were obtained. Till date, we have around 4 studies with 195 patients, which reaches us to which has a sensitivity and specificity of nearly 70%, sensitivity of 70% to a specificity of 92%. This gives us a diagnosis of UIP versus non-UIP rather than IPF versus non-IPF. Here again, we have a good specificity. So from a clinician point of perspective, we can say a UIP pattern is acceptable, as a result with UIP pattern is acceptable. But when we get a non-UIP pattern, we are still nowhere with a sensitivity of 70%. That would literally mean like we are missing 30 of 100 cases. Deep machine learning is another modality which has been involved with radiology, again having very low sensitivity and specificity, which probably is still not at a point where we can use in our clinical practice. So in summary, it is really of utmost importance for us to accurately diagnose or type ILDs. Splitting and lumping of ILDs should be complementary to each other. And precision medicine in ILD, a tremendous progress has been done, is being done in the last decade, and there's still a long way to go, but future is really exciting for precision therapy in ILD. Thank you.
Message which you have given actually. So in addition to what he has said, I would like to just bring your notice to the 2 important registries which have been published in the last 5 years. Prior to the publication of these 2 important registries, our understanding was that IPF is the most common cause of interstitial lung disease in India, which has a poor prognosis and rapidly progressive. And we didn't have therapies also before the advent of this pirfenidone and nintedanib. However, in the last 5 years, we had 2 important registries. One is the Indian ILD registry, and the second one is from PJ, where Dr. Inder is also part of it. So both of these registries have shown that in India, the most common causes of ILD, in one of the registry, it's the hypersensitivity pneumonitis, and in other registry, the commonest cause of ILD was sarcoidosis, though there might be a referral biases. And the second most common cause of ILD in both the registries was second or third most common cause was CTD related ILDs, accounting for around 15%. So if you look at the incidence of ILDs, so hypersensitivity pneumonitis, sarcoidosis, and CTD ILDs are the 3 important causes of ILD in India. And as we know, most of these things are very well treatable. So there is always an important point to make a diagnosis in this patient. The theme, since it being is it necessary to make a diagnosis, as it's really important because most of the common causes of ILD which we encounter in our practice are very well treatable with the anti-inflammatory therapies which are available to us. So rest of the things, as I said, there are numerous conditions where probably we can specifically look at the gene and see which therapy to be given and when to give only steroid anti-inflammatory and when to add antifibrotics. He has brought out some important things actually. And I would like to ask my co-chairs and also invite questions from the audience.
Dr. Vishwanath and honorable chairpersons, I just like to share one thing. The interstitial abnormalities, and in fact, having been situated in the periphery of Hyderabad in a peripheral medical college, I am seeing quite few cases of the interstitial abnormalities. In fact, it's very important to diagnose this thing. And what I am finding that these are more located or more occurrence, incidents, is in agriculture workers and the workers who are dealing with bricks and other sand workers. Diagnosing this interstitial abnormalities is a very important thing because, as he has told, next thing it's going into the irreversible this thing. And most of these cases are being labeled as asthma. And it may be even allergic alveolitis also, which we are not able to diagnose to say that it is allergic alveolitis. However, that also comes into the purview of this interstitial abnormalities. It's very important to diagnose and say that thing, that it's an interstitial abnormalities or this thing rather than fibrosis, because we can still prevent from that patient from going to interstitial fibrosis, which is a permanent affair.
Not a question, but just a comment. Over the last decade or so, there have been developments both in drug discovery as well as in the genomics. In fact, genomics has given rise to the precision medicine. And genomics started with the discovery of the double helix in 1953. After that, there have been multiple innovations, and that has given rise to more data. And it is important that as clinicians, all of us have to document whatever we see in our patients. This documentation is done more easily in the electronic medical records. So I urge all our practicing doctors to start using electronic medical records, because electronic medical records will generate what is known as the big data. And from the big data, we get what is known as the machine learning. And from the machine learning, we can create algorithms, and that would give rise to what is known as the artificial intelligence. So whatever we have, whether it is regards to asthma or ILD, it's simply based on machine learning and artificial intelligence. So a long time ago, Sir William Osler, who is considered as one of the greatest clinicians ever, has said, look for the patient who has the disease. Don't look for the disease in a patient. So when you look at the patient, you get a lot of things, like Dr. Sandeep mentioned. What is his age? What does he want? Where does he come from? So this comes from the history again. So meticulous jotting down of all the details of the history will give you about the details about the patient. And then, of course, you look at the disease. So when you look at the patient, you get the data which is required for phenotyping. Phenotyping is nothing but looking at the physical things like age, gender, etc. So when you couple this with the environmental factors, the social factors, then you can come with the answers that is required for the precision medicine. So the short and sweet message is documentation of the details of the patients. So that will lead, and very nicely put the interstitial lung disease. And definitely between the two studies, I would like to go more with a study which was done earlier, which showed hypersensitivity pneumonitis as the most common, because that is what I see in my practice. Next comes the connective tissue related interstitial lung diseases, and lastly the idiopathic pulmonary fibrosis. And now we are doing more of ANA profiles, all of us who are sitting in the hall. All of us, earlier we were not doing as many tests as now. So today we do not hesitate if we are convinced that it is not IPF, and if we are convinced it is not HP, and then we would like to investigate further by doing the ANA profile. And many times it so happens that the connective tissue symptoms and signs come much later, maybe a year later or 2 years later, and the pulmonary manifestations come early. So probably the pulmonologist will be the first one to diagnose the connective tissue disorder. Yes. And sometimes even the ANA profile may come negative initially, but a subsequent repetition of the test, maybe 6 months later or a year later, will come positive. So this has been my observation. Thank you.
Yeah. That's true, sir. first is TOLIP-TT and N-acetylcysteine. That leads us to a topic of pharmacogenomics that will go towards precision medicine in the days to come. Pharmacogenomics in asthma also, pharmacogenomics in every clinical respiratory diseases. So pharmacogenomics is another way for precision medicine days to come. Thank you.
Dr. Vishwanath, you have quoted two registries. One is Indian registry of ILD and also the PGI. Among these two registries, the Indian registry is a multicentric. So it gives the data of the entire country, whereas PGI is always there is a referral bias. We don't see more of sarcoid-related ILDs, even in South India also. Still, I think the Indian ILD registry, the most common is the HP. I think our experience in South India.
Yeah, his point is just one point actually.
Might have been representative, but the biopsy rate was so it was primarily based on radiology. See, radiologically, SP could also look like IPF. IPF could also look like HP. So we have to come at a middle path.
In there, I do agree.
No,
but let us not go into
the point of only bringing that point, the reason for bringing up the point was not to debate which is the commonest cause of ILD. The only point was most of the ILDs which we commonly encounter in our practice are reversible, and if they're able to treat it appropriately.
Even the Jaipur registry is north-centric. There have not been many samples coming from the south. So again, you can say that there is a bias. That's the reason why the HP was more common, because most people were exposed to the biogas.
Air coolers are also the commonest cause.
Air coolers. Here people use air conditioners rather than air coolers. So
probably we need to have one more South Indian history where we can.
Correct.
Yes. So the idea was to bring about only that, sir, actually, to say that it's most of the causes of ILD in India are actually treatable in early stage. And if there are no further questions, then we'll close the session. And thank you very much, everyone. And thank you, Nagarjun, for a wonderful academic feast. This has been an evening very well spent. Thank you very much, team Yashoda.
Thank you, everybody. I think it was an excellent session overall. Dr. Inderpal, sir. Dr. Sandeep Salvi, sir, please. And Dr. Raghava Rao, sir. Thank you, Gangadhar, sir. Thank you very much. May I call upon stage Dr. Vijay Kumar, sir, and Dr. Subhaka Kandi, sir, to present mementos to the chairpersons, please. Dr. Pravakar Rao, sir. Dr. Narendra, sir. Dr. Tapaswi, ma'am, please. Dr. Mahinder. Dr. Chandana Reddy, ma'am. Dr. Bhaskar, sir. Dr. Vishwanath Gella. And Dr. Amjad. I'll now request Dr. Nagarjuna, sir, deliver the vote of thanks, please.
So before we break for the dinner, which we are eagerly waiting for, I just like to end with a 30 seconds vote of thanks. I would first like to thank all the speakers, especially Dr. Sandeep Salvi and Interpol, who is there outside, for coming over here and delivering their lectures full of wisdom. Also like to thank the national speakers and chairpersons and also the delegates for coming on a Wednesday evening, which is again, I understand, very difficult. Also like to thank our hospital administration for providing us the platform, because of which we're able to organize this academic event. And a lot has to go behind when we plan an event. I'd also like to thank our marketing team headed by Pradeep and everyone, the branding team, all the images, videos which you are seeing are the hard work of our branding audiovisual team, which were headed by Sandeep, Sajan, Sham, and so many people who are there behind running the show. And a special mention to our team. So I would completely agree that it is never a one-man show. It is always a team which is working in hand. A special round of applause to Pratip and Amjad, who are there with us. And mentioned to Dr. Alekia, all the data which I was presenting was analyzed by Dr. Alekia, who also happens to take care of our specialty clinics, and also to all our team who have been there supporting and doing all the works of the inpatients and OPD while we were working for the event. I think with this, we will all break for dinner, and also special thanks to AstraZeneca, who were the company which has given us the push to start the severe asthma prevention clinics. And with that, we started off the ILD and every other clinic. I think we should thank AstraZeneca for being there, for giving the impetus to start the severe asthma precision clinics. Thank you. So we'll all break for dinner, which is there in the balcony, and then we can call it a day. Thank you.